Hello?
Hello?
Yes, Dr. David Becker, we can continue. Extremely sorry for the delay.
That's all right. Just if I share my screen now. Oh, Wendy. I'm going to just... Okay, I'll just try and... It's now asking me... Oh, bear with me, it's asking me to quit and reopen now. Oh, hang on.
Yes.
I'll be 2 seconds.
Yes, sir.
Okay, fantastic. Good morning. Thank you for persevering there with getting us online and stuff. Hopefully everyone can hear me clearly, which is fantastic. It's currently 4:20 in the morning in the UK, but it's a massive privilege to get up and present this brief presentation to you. I'm awfully grateful to be invited, which is super main message as well. Yes, okay. I'm thrilled to be invited to present this basic overview on endodontic microsurgery. So my name is David Baker, and I qualified in Liverpool in 2004. I was a young picture of me in 2004. And after qualifying, I always knew I wanted to do something involved with endodontics. So I completed a master's program in endodontics at the University of Central Lancashire, and then limited my practice pretty much to endodontic treatment. I became a trainer with Dentsply as well as Colty, and there you can see I met Professor Abrar over in Switzerland, which was fantastic, and we've kept in touch since, and I'm awfully grateful that he's invited me to various collaborations with him, and this being another one. I also run a private practice with my wife just outside Liverpool. This is 183 Dental, where I accept endodontic referrals locally. So I live in Liverpool. You might be familiar with Liverpool from the Beatles. my school was on Penny Lane, so a big history of the Beatles in Liverpool and music generally. This is the waterfront at Liverpool, so voted the European Capital Culture some years ago. And obviously the big passion I have, proud to be from Liverpool, but equally proud to be an Evertonian. So I don't know if anybody follows football, but we're not doing very well at the moment. But this lets out all the frustration at the weekend. So that's a little bit about me. I also teach here in Simply Endo, my partner, in a master's program that we run at Simply Endo. So feel free to check us out or follow us on Instagram. So today we're going to talk about endodontic microsurgery, and before we get to that, we need to really consider what success in endodontics really is. A colleague of mine used to say, you're only as good as your last endodontic treatment, and it's about making sure we do the best job we can for patients when we do endodontic treatment. And if we're quite specific about looking at success, we would say that success would either be a lack of apical periodontitis, so in other words, it doesn't appear after treatment, or resolution if there's apical periodontitis there to begin with. That's our radiographic things that we're looking for. But clinically, it'll be a patient who has no signs and symptoms. So if they had a drain and sinus, for instance, to begin with, that drain and sinus is resolved. If they had symptoms of discomfort or pain, swelling, hopefully they've resolved. And in the paper here from the Toronto study, they excluded tendons to percussion. I think they imply that tendons to percussion could be there from maybe periodontal problems or occlusal problems. Hopefully those patients come back and they have no tendons to percussion, but it probably shouldn't be something that would totally influence the outcome. So that's our rough definition of success. And we know endodontic treatment works. We know if we do things right, we do get success. The way of getting things right is if we reduce those bacterial levels to negligible levels inside the root canal so that the body can deal with it. We want to prevent our endotoxin from reaching the apical tissues to promote that immune response. And we do that obviously by sealing any bacteria in, so incarcerate or entomb any bacteria that's left behind in those negligible levels, and then seal everything really well. So seal everything from a coronal, apical and lateral point of view as best we can, so to prevent tissue fluid and nutrients getting back to any bacteria that's there. But unfortunately, we have this problem as well with endodontic treatment, that we know that we might do everything perfectly or perfectly in our mind. And unfortunately, things still, don't work. And there's this whole thing of, can well-treated teeth fail? It's a fantastic paper here from Jose Sequeira, based in 2001. And what they talk about in this is about those well-treated teeth that fail. And they give some justification for why that might be. Some of the reasons why that might be, so intraradicular infection. So maybe you didn't quite get rid of all the bacteria. It was maybe more resistant to the things that we do. And we know that some bacteria is definitely more resistant to others. Extraradicular infection is an important one. So extraradicular infection, if there's infection on the outside of the root canal space, it doesn't matter. We could do all the cleaning in the world inside the root canal, but if there's infection on the outside, then that internal cleaning is not really going to do anything. Actinomyces is one of the bacteria that gets involved with extraradicular infection. It's mentioned in the paper overfilling. I won't get into overfilling and overextension, slightly different terminology. Essentially with overfilling, we can overfill because we can push surplus through the end of the tooth. And the body copes quite well generally with GP and sealer. Where it doesn't cope particularly well is if we damage that delicate the obturation material, confine it to the root canal system. So overfilling, particularly damaging the constriction, can lead to poor outcomes. Our coronal seal, so we know how well we seal everything. So there have been plenty of papers over the years from Saunders. There was the Ray and Trope paper in 1995. Knowing that how we seal things afterwards is mega important. It's mega important not only from sealing everything so we can't get bacteria re-established inside the canal, but also from a structural point of view as well. Most teeth that we do endodontic treatment probably fail from restorative reasons, so restoring it restoratively afterwards. There's a strange one in this paper, which is non-microbial causes. And in the paper, they refer to various things, and some of them are materials that have been pushed through the apex. And I know one of the cases Professor Syed asked today is about, I think, a calcium hydroxide case where calcium hydroxide has gone through the end and the way the body's reacted to that. Things that I mentioned in this paper, it talks a little bit about obturation material, but then it also talks about some strange ones. So things such as cellulose from a paper point, from pushing paper points too far and debris being left behind. It also talks about food particles. So if somebody's had a tooth that's maybe been left on open drainage, or if caries has meant that the pulp's exposed and it's necrotic and food's going, it talks about food particles being wedged into the apical tissues, causing a pulse granuloma. With that as well, non-microbial causes cysts, so cholesterol crystals that are in cysts can cause ongoing problems. And the last one, and one that people sometimes forget, is poor host response. So I often tell my patients that root canal treatment puts the building blocks in place for the body to fix itself. I don't treat somebody differently, particularly because they've got diabetes, but I know the outcome for those patients can be poorer than a patient who doesn't have diabetes. But I've not done anything different. It's their response to it. And hopefully if the immune system is good and they're nice and fit and well, they do get good outcomes. So an interesting paper to look at of why root canals that have been filled well can fail and some of the general reasons for that. When we've got a case, we'll do a primary endodontic treatment. If that case fails, we might consider a secondary endodontic treatment. If that case fails, we might consider a surgical approach. And if that case fails, you might not, but you might consider surgical retreatment. And there was an article from Trope which suggested if we started off this cascade with 100 teeth at the top, so many of them would fail. Then the secondary endo, so many of them would fail. Surgical endo, so many of them would fail. And surgical retreatment, so many of them would fail. But out of that initial 100 teeth that were treated, Trope suggested that it would only be 3 extractions. So we know that our primary treatment works well, our secondary treatment can work well, surgery can work well, surgical retreatment working less well. But if we follow these patterns, we tend to have good outcomes. There's that thing that maybe we're not failing when we do these things. Maybe we just haven't found a way that works. Maybe when those things fail, it's not a question of well, actually this has failed. It just means you have to do something different in order to get it to work. I often say to patients, there's so many things we can do to try and preserve teeth. Sometimes it depends whether they want to do it and whether we want to do it. We've now got this idea of surgery versus retreatment, and some people might skip the retreatment bit and jump to surgery. And you need to ask yourself, is that a sensible thing to do? Skip the retreatment and jump to surgery? Well, there's no difference statistically between retreatment and surgery in terms of success rates. A paper from Quist in 1999. What they did suggest, though, because we're going in and physically curetting out the infection that's there, then you tend to get healing a bit quicker with surgery, but then you might get later failure. Because we come back to that thing about endodontic treatment, put the building blocks in place. When we retreat something by non-surgical ways, we are relying on the patient to then get better. We're not really giving them such a big head start as surgery gives them. So this is quite a busy slide, but I think it's quite a good one to look at. So with this slide, when we've got someone with irreversible pulpitis or periapical disease, then we're going to look at whether we're going to think it needs endodontic treatment, but we need to make an overall assessment. So assessing the tooth prognosis, both perio, restorative, and the endodontic treatment. If we've got a negative outcome, if we think actually this is not worth doing, then we've got choices of leaving and monitoring or extracting the tooth, unfortunately. If, however, we tick those boxes and we think this is feasible, then that's our positive outcome, and we can carry on with our primary endodontic treatment. Assuming that gives us a positive outcome, then you would just leave a monitor. And in the UK, we follow the ESE guidelines, so that would be monitor that tooth every year for a period of 4 years. If, however, we've got a negative outcome, then we decide the tooth's untreatable, then the only thing we can do with that tooth is probably take it out. You could argue you could monitor it, but probably take it out. If you actually think this might be feasible, there's intracanal infection, it might be feasible to do something, then we can do our non-surgical retreatment. And again, looking hopefully for a positive outcome. But if there's a negative outcome, then unfortunately we're back to extraction. Or surgery. The other thing we've got with negative outcome, if we've got an isolated periapical infection, that also ties in with surgery. So a couple of options to get to the surgery. Monitor it then for a positive outcome or a negative outcome. If negative
Recording
outcome,
in progress.
we're back to extraction. Then we've got a last choice really. If the root canal is not accessible for whatever reason, let's imagine somebody put a post in it or something like that, then you've got surgery as an option. Or you might decide something a little bit more heroic, which I'll mention a bit later on, which is about hemisection of teeth. And again, you follow this positive negative outcome, and hopefully we get positive. If not, unfortunately, it's time for forceps, unfortunately. So it's all modified a little bit that from a paper by Zipman, and it's quite a complicated slide, but hopefully easy enough to follow there. What is endodontic microsurgery? So it's a surgical approach that we carry out when orthograde endodontic treatment is not feasible, or orthograde retreatment has been done, and then it's silly to do it again, really. What I want to talk about very quickly here is the difference between contemporary endodontic surgery, contemporary endodontic microsurgery, and the traditional approach of endodontic surgery. I was taught at dental school the traditional approach of endodontic surgery, and I showed quickly a little bit what some of the differences might be. So, with our magnification, most of you hopefully will be using magnification, but with magnification, the traditional approach was not. To have magnification at those times, it wasn't available, so people used their eyes. With the contemporary approach, hopefully we're still going to use our eyes, but we're going to use a microscope or loupes. And it's fantastic to see so many dentists out there using loupes. The difference between loupes and a microscope is amazing though. You know, most loupes I see in the UK probably go up to maybe at most 7-8 times, if that. Most people are around the 3.5, 5 times loupes. My microscope goes from 3 to 23, and I'm probably using it generally somewhere between 8 and 12 most days. So a big difference with loupes over a microscope over loupes. In terms of our incision, we're going to potentially use a surgical blade with a traditional approach. I'll show you this in a bit, but we're going to use a microsurgical approach with a contemporary endo. The osteotomy, so the size of the hole in the bone, traditionally would be a bigger hole because you need to be able to see. But now that we're using microscopes and magnification, you can make that a bit smaller, which heals quicker. The root angle bevel, I'll show you again some images of this, a little cartoon of what to do. Typically it was a 45-degree bevel. With the traditional approach and the contemporary approach, it's more like to be a 90-degree angle. The retro prep, so how we prep that, how we create the hole in the end of the root canal in order to restore it, to put our retro filling in. Historically it was with a burr. More often than not now we would use ultrasonics. Material, amalgam, and you still see plenty of these every now and again. You'll take x-rays of people and see they've had endodontic surgery carried out and it's been sealed, retro prep and filled with amalgam. More than likely now we're using bioceramics, so MTA, bioceramic putty, those sort of things. How we suture things, historically it was a 3/0 silk. You got a bit more scarring with that, and now we're looking at using 6 or 7/0 monofilament sutures, which resorb. When you would remove sutures, used to suggest we'd leave patients for a week, even longer sometimes. Again, causes a lot of scarring. Now you might consider doing it within 48 hours post-op. Outcomes of these things, some of the old studies still had reasonably good success depending on the time limit, but generally now we get good success with our contemporary microsurgery. And the last one, guided. So guided, now, it wasn't even considered years ago, but now guided endo, definitely something we would consider. And obviously Professor Said shared a case with me on guided endo, which was just phenomenal. So yeah, very clever. Really what we're looking for with this is vision, isn't it? It's vision, so magnification and lighting makes all the difference. In terms of magnification, the benefits of using a microscope, I could go on for lists and lists, but posture, sitting up straight, you see the chap in the picture there straight. You get less eye strain with a microscope than you do with loupes. Microscopes, you will focus to infinity with a microscope, whereas loupes, your eyes have to look inwards ever so slightly. Some people struggle with loupes a little bit. You can look for things that you wouldn't have seen otherwise, so cracks, and really assess the remaining structure. It makes treatment a lot easier. You can make everything that little bit smaller. This question mark about accepted standard of care, certainly when patients come and see me, they'll often comment that their own dentist doesn't have a microscope. They think that that's going to make me better, and it's not always the case, but it does help. Let's look very quickly, just step by step, through each of the steps for surgical endodontics here. Like I said, we're only a short presentation this morning, so I'll be quite quick with some of these. Local aesthetic, given good local, is really important. It depends what is available for you in our country. These are the locals really that are available for us. We have a couple of others, but we don't have anything with better vasoconstrictor properties. So I know in America there's 1 in 50,000 adrenaline, but in the UK that's not available. So I tend to use a cartridge of articaine. Give them buccally, and then let's assume this is an upper lateral. I know some of the cases that have been shared with me were upper lateral, so let's assume we give a cartridge buccally of articaine, and then 2 to 3 cartridges of lidocaine, with a decent amount of lidocaine given palatally as well. Obviously the benefit of vasoconstrictor from a bleeding point of view, but also you need time. You need time for this to work so the patient feels comfortable, but for the local to have its vasoconstrictive properties to work as well. Our flap design, the benefits of the flap. This depends a little bit on how we're doing things. So we need to, the whole objective is that we're going to access the periradicular infection that's there. Depends a little bit on the periostatus. I'll show you some flap designs. It depends a little bit on the restorative situation of the tooth. So if the patient has a crown or a bridge or something along those lines, we don't want to get loads of recession around that, because that will look particularly ugly. The biotype will make a difference. If someone's got a thick biotype, you do need to watch out for muscle attachments, so frenums and the bulbosity of canines, and also structures like mental foramen and stuff like that. There's certain teeth that I tend to keep away from. In terms of blades that we would use, that's a microsurgical blade at the top, so it cuts all the way around. And the difference between that and the traditional Swan Morton surgical blade is phenomenal. So much more control using a microsurgical blade than one of the traditional blades. It might be personal choice as well, but for me, the microsurgical blade, hands down, is the one to use. These are our basic flap designs that we'll touch on a little bit. I'm going to show you in the groups of two and then 2 others. So there's 2 that potentially I wouldn't do a lot of, to be fair. The intrasulcular one, I've drawn a little cartoon here because I know, like I say, one of the cases is a lateral, so I just threw a little cartoon of a lateral in. So assuming we're treating this tooth, the intrasulcular one is sort of the traditional, the one I was shown at dental school, so we would come all the way around the papilla, the whole thing gets retracted. It's quite a nice flap in terms of being able to see everything. It's a fiddly flap to do in terms of coming around the papilla, and you can make a mess of it really coming around the papilla, and then it can be tatty putting it back together. You do get more scarring with this sort of design, and therefore more recession with them. So if somebody had a crown or something like that, it can look pretty ugly afterwards. But loads of access with them, which is good. The next one is one that is probably rarely recommended, the semilunar flap. Not a particularly good flap in terms of preserving blood supply, not a good one in terms of, our flaps should be on sound bone, and sometimes these sort of flaps aren't, particularly if you've got a big lesion, there might not be enough access to get in and do it. It's sort of a bit of a lazy flap when you do this. There's better designs to this, although it's one that's mentioned in the literature, that for me there would have to be specific cases of why I was doing that one. You have to be a little bit careful across the muscle attachments again with this one, and in this situation, on this crossing the canine like that is probably not the best thing to do. 2 of the flaps that I would recommend are these 2. So the papilla base flap, which we probably consider as the default one, is a tricky flap to kind of do. And then the other one, the submarginal one. The submarginal one, if you lack a little bit of confidence with papilla base, submarginal one is a good one, and is probably one that I probably do reasonably frequently. It's probably a 50-50 mix of these 2. You do need decent perio attachment with this, and you need incision needs to be against sound bone and not directly over the lesion. So this is the submarginal one. So it's just underneath, just where that little attached gingiva part is. So in the thick part of the gingiva, if you like, These are scalloped around the edges, and as long as you're over sound bone, give really good visualization when you retract them. They're nice and neat to put back together. They tend not to scar particularly ugly or anything like that. So yeah, a nice one to do, particularly if you were starting off as a beginner, really. The other one, which is more complex, is this papilla base or papilla preserving flap. So we come round and we scallop around the papilla, and you have to go in initially at 90 degrees and then 45 degrees with this. So it's a slightly fiddly way that you cut these. The beauty about this is when you put it back together and it all goes back neat, you get very little recession, if anything at all. It just doesn't, because the way it's attached to that papilla. There used to always be a panic that the blood supply of that papilla would be compromised, and it really isn't. Super nice flap to do. Then when we think about retracting the flap, in other words, pulling the flap back so we can make access to the lesion. Yeah, I've written this about careful but assertive. You need to start where the flap comes across the teeth, so that where the relieving incision is, and then work along the horizontal and use an elevator to just slowly peel it back. One of the things you can do with the local anesthetic is if you sneak the local anesthetic, one of the cautious local anesthetic, directly under the mucoperiosteum, it sort of balloons up a little bit, and that makes peeling it back a little bit easier. So down to bone and then peel it back. Like I say, careful but assertive, because you don't want to damage the flap. And if something is starting to not quite work, just go back and look at your incision. The incision needs to be very particular that you've actually made an incision. People have this habit of going down and up, and they punch holes along the flap as they go. You don't want to go down up, you want to make good incision and then peel it all back. Once the flap's peeled back, then you can use something like this Minnesota retractor. This retractor is there to hold the flap back and keep it out of the way and keep it nice and safe. And this is one of the occasions where working with your dental assistant is important, because she or he might hold the flap back. These are highly polished, so sometimes you can use them also almost a bit like a mirror, so you can sort of look in them and get indirect vision against the retractor. I've written there about grooving bone. Sometimes people will, to hold the retractor in the right place, some people will score a little groove in the bone. It's not something I personally do, but it's something that's mentioned, particularly if people are nervous about if they were doing surgery like near the mental frame, they might score a line above that, and then so they know the retractor doesn't go anywhere near it. But not something I personally do, but something you might see on various demonstrations. Then obviously there will typically be a big hole in the bone. That's obviously, and then the hole's there. You might modify it slightly. Historically, we used to use the surgical hand pieces. I use something like this, so 45-degree high speed. What's important about these is the angle of the head of the high speed is really important, so it gives you really good visualization of what you're doing. But also it's in reverse exhaust high speed, so the air isn't being blocked out through the front, it's being taken out through the back of the handpiece. And that's really important, because if you blast loads of air into these things, there's a potential risk for what we refer to as surgical emphysema, so getting air bubbles inside the soft tissues and stuff, which there's some studies that say it can be particularly dangerous, others say it's not. Probably something you would want to avoid. If you're not using something like this and using surgical hand speed, slow speed sort of surgical burr, and you need to use saline, so something where the nurse might drip saline over the top if you don't want to heat up the bone, so don't damage the bone. Really important. Keep that crypt nice and neat and small, but enough so that you can see what you're doing. In terms then of removing the lesion, again, sometimes people will do this different ways, and it's worked both ways for me sometimes. Sometimes I will do the resection of the root, and that comes, all the lesion comes with it. Sometimes you go in and physically curette it all out. The lesion is often responsible for lots of bleeding. I had a case just recently, and the amount of blood from the case was just incredible, and it was such a grotty lesion when we went in. But once that's curetted out and you're down to sound bone, the lesion's gone, and then generally bleeding tends to stop. I think if you're working in a hospital environment, you're more likely to send these off for histology. It's probably a good thing to do. It's a bit more fiddly in the UK with private practice. A bit of a hassle sometimes. The majority of these things come back just as granulation tissue, occasionally abscess formation, or sometimes cysts. It's sometimes incorrectly diagnosed. Sometimes it's diagnosed because there's epithelium that runs through the lesion rather than it being circumferential. Sometimes it's nice to get an idea what it is, though it's rare for it to be, thankfully, anything sinister. In terms of control of bleeding, I think this is probably the hardest thing with apical surgery. I think there's various things that you can try and use. For me, really good local anesthetic makes a difference. You can get these things like these racelet pellets, the adrenaline pellets. We use some of these gelatin-based type things and cellulose things in the practice, sort of almost like sponges and stuff. There's a paper here where it talks about ferric sulfate and calcium sulfate being appropriate, but also suture when you're done, putting everything back together. But initially that you've got to be careful with that bleeding so you don't get a washout of your retrofill material. Case selection is obviously important, and if patients are taking various medicines, so I presume medicines are mentioned the same for yourselves, but for us, things like some of these medicines like people are taking for atrial fibrillation to thin the blood, they take things like apixaban or edoxaban, or some people taking things like aspirin and stuff like that. You have to just be a little bit careful with patients that you're treating sometimes. And if it's not in your comfort zone, you refer it to somebody else. It's just a little bit of a crude diagram, but hopefully it explains things really well on root resection. So with root resection, what we need to do is we need to remove about 4 millimeters of that apical part of the root. And the reason we need to do that is because that's obviously where this infection is based, in the granulation tissue. There might be this extraradicular infection attached to it and biofilm attached to it. We might not have sealed it very well apically, but also we know that in that last 3 to 4 millimeters of the root is 75% of lateral canals. So this suggesting that we remove 4 millimeters of the root. Now, historically, what we would do then is we would do this on a 45-degree angle. So this 45-degree bevel, and the reason why we would do that is because we were using just our eyes and not magnification, and that meant that we were looking at it from this point of view. And when you're looking at it from this point of view, you want to be able to see the end of the root so that you could then place your retrofilling, which in this case was amalgam. But straight away you can see a fundamental problem with this. We've removed 4 millimeters from, say, the buccal aspect of this tooth, but we've not removed 4 millimeters from the platal aspect. And that means potentially lateral canals are left behind, infection may be left behind, and also this type of angled bevel opens up more dentinal tubules, and in doing that you're more prone to leakage. So one of the big things moving forward with contemporary, with microsurgery, is that we're now in a position where we're still able to remove 4 millimeters of the root, but this time we're going to remove it at 90 degrees. And the reason we can do that is because we're going to use micro mirrors because of our magnification. These little micro mirrors are fantastic. You go in, you look at them under the microscope or with high power loops, and you can see indirectly the end of the root canal. And that means then we can do our retrofilm like that. But you can see the benefit straight away in removing that apical part of the tooth, doing it properly. So there's our retro prep. People are more likely to use ultrasonics. I know some dentists who still try and use handpieces and things, but ultrasonics can wash everything out. Ultrasonics are lovely because if you've got something like a 4 or a 5 or something where an MB of MB and an MB2 of an upper 6, you can go between those canals and get rid of the groove or the fin that joins them. So you can use that. Ideally, they talk about going to at least 2.5 millimeters. I think you're probably going to go slightly more than that anyway, because you want to try and put a decent seal in. And there's the thing about staying in the canal. Don't veer off track. So stay in the canal. Various ultrasonics are available. It's good to have a couple of selection of them. But definitely ultrasonics is a nice little thing to do. It removes your GP, and then you can fill the end of that. In terms of filling the end of it, as I said, amalgam is something that's been used over the years, but we probably wouldn't encourage that nowadays. You've got better choices. So MTA-based chemistry, so original ProRoot, ProRoot Grey or ProRoot White, they're still not much better, I don't think, than ProRoot, just in terms of how it handles. I do like some of these bioceramic putties. This is one that I use, this WellRoot one. It comes in little composite type capsules. You can put it onto a little pad or directly in with a composite gun. So bioceramic putties, a few about. I get that from a place called UK Dentistry in the UK, and fantastic stuff comes in these little sachets. Biodentine, it's quite a nice material in this sort of situation. I quite like biodentine for vital pulp therapy, probably more than this sort of thing, but some people do swear by biodentine. Obviously, other choices that have been mentioned historically, Super EBA and IRM, both with good results over the years. Place this with your pluggers, or sometimes packing it in with the ultrasonic as well. Clean out the crypt so there's not all root filler material in there. And then it's a nice opportunity now to check a radiograph. You don't have to do this, but it's a nice thing before you seal everything up. So you could check your radiograph and go, actually, I'm happy with that, and then seal everything up. In terms of resealing everything up, as I said before, some of these suture materials are far better than silk. These are nice and thin. They resorb and look nice and neat, although we're going to talk about whether we leave them to resorb or not. A little 3/8 circle needle, and try to not have this massively under tension, the flap. Don't want it crazy tight. Just nice and neat. Put it all back together, and all will be good, hopefully. It's a good idea to give patients some post-operative instructions. There isn't normally a need for antibiotics unless you felt there was something in their medical history that made a difference. You can apply cold to the area, so as in the patient, you go home, sort of we used to talk about a bag of frozen peas or that sort of stuff onto the side of the face, something cool that day, particularly to reduce the swelling. Advise them to be careful with how they're brushing and that sort of stuff. Reassure them. Sometimes patients don't realize they might be bruised afterwards, so reassure them, bruising is to be expected. This idea of over deliver and under promise, is that the right phrase? I've said that wrong way around, haven't I? Over deliver and under promise, isn't it? So you would tell them, you feel quite sore over the next couple of days, or you might feel quite bruised, and then they won't feel that bruise and they won't feel sore, and they're quite happy with you. But reassure them that if they are bruised, that's possibly normal, and any problems, they should give you a call. Avoid alcohol and smoking. That's the patient, that's not yourself. Avoid alcohol for that day, and smoking can be detrimental, can't it? It's worth giving these as written instructions to the patient. We know patients like to forget stuff. We tend to give them as written instructions, but also send them an email, which is quite useful. Then you have to review the patient. I think one of the things in Endo that we do a lot at the practice is phone the patient. So I get someone on the team to phone them probably the following day. I do it with lots of cases, to be fair. Patients are often pleased that you've made the effort to ring them. And it's rare that there's problems. But if there are problems, at least you can schedule them a little bit easier than the patient phone up when you're not expecting it. So I get someone to give them a call. Ideally, remove the sutures after a couple of days. You don't want to leave them there for weeks, because you're more likely to just get scar tissue and they get sort of grotty and food debris and stuff around them. And then we'd follow these up for a period of 4 years, every year, taking radiographs and checking things clinically as well, looking for signs of healing. And more often than not, you will see good healing even at 12 months, and then hopefully over a period of 4 years. Obviously, if you see things that are unpredictable, you might decide whether just to continue monitoring it, or you might decide to intervene and do something else. We do have a couple of alternatives to microsurgery, which I'm just going to touch on just the last couple of slides. Hopefully some of you found this useful, but these are just slightly different. So you could leave a monitor. So if some things, you decided not to do, you could obviously take the tooth out, consider whether they have a gap, a denture bridge, or an implant, or this thing, decompression, or hemisection. There's decompression that I just want to touch on just for a second, because it's quite a nice case to show. You've actually seen the x-ray already there. So I come across decompressions from years ago working as a senior house officer, when one of the oral surgeons I worked with cut the finger of a glove off, and he sutured the finger of a glove into a draining sinus to allow it to drain. I didn't really understand what he was doing. And then I come across it again in this book by Richard Schwartz, which is a fantastic book, although a little bit dated now, but a fantastic book. And what they suggest in this was making an incision into a lesion that was draining, but they couldn't get under control. And what they do is they suture in the end of a mixing tip into place, and this is effectively acting as a vent to vent the infection, to allow it to reduce in size. So then maybe either somebody can go in and do conventional treatment or do surgery easier. This was a case that I did with a colleague of mine. So it was a case that I tried to treat. This was a retreatment, so someone had already had a go doing this some years before. Patient never felt right, and he kept getting a swelling on his palate. So we tried to retreat this non-surgically, and just couldn't seem to get it to settle. It was sort of starting to get to settle around the end of 2019. I saw him early 2020, and things were getting a bit easy, and we considered whether we should fill it. And I dressed it for quite a long time with calcium hydroxide, and then unfortunately, as you all know, unfortunately 2020 COVID happened, and then this guy disappeared for a while, and then when we returned, probably about 18 months later, this lesion had just got bigger. So I chatted with some colleagues of mine. We got a CT scan of it, and the lesion was huge. So we knew that if we were to intervene, we were likely to create problems, probably for other teeth. It was too big a lesion to sort of take the tooth out and expect them to get an implant. There just wasn't the bone. So we thought if there was some way that we could bring bone back, even just a little bit, so then even if you then lost the tooth and had an implant. So we did this decompression. So some of this surgery is done by a colleague of mine, Dr. George, fantastic oral surgeon. So George, this was a lesion that I was happy for George to do. This wasn't one that I was desperate to do. So raised the flap, and he's done the full thickness flap, as you see, the one that often we don't do, risk of scarring, but you can see the patient's got nothing restorative on these teeth, so he's not going to see crown margins or anything. So retract the flap, and then George has placed then a little pipe, again, a bit like from a mixing tip. This is to allow it to vent the infection, and this gets sutured into place within the bone. And then the gum tissue was all put back. And this was there probably for about 12 months. The patient had to irrigate it every day with saline to keep it nice and clean, and he was reviewed every week. So quite a big commitment from the patient, but he was desperate to do something with his tooth. After this was all done, flap was then raised again, and there was nothing really to clean out. The end of the root was resected, MTA was placed, and then I actually obturated it. We did it a bit back to front, so the MTA was placed before the obturation, which made it a super easy obturation. But you can see we ended up with quite a nice result. That was over a period of about 12, 13 months, something like that. So good patient, good cooperation with everything, and a good outcome. I'm being rang by Wendy. Hello, Wendy. Oh, Wendy's gone off. She was ringing me. Last slide or so anyway. And this is one on hemisection. So this is a patient that was referred to me, and we thought the upper right 7 was fractured. We noticed then on a subsequent radiograph that there was a fracture, and some people would think the tooth was probably, oh, please hold on for a minute. Oh, I'm being asked to hold on, no problem.
Hello.
दोन सिस्टम झाले का? ओके. 1 2 3 सांगा मला. I will invite you and get aside. You come. Good morning, everyone. I thank all of you for being a part of this program. With a lot of respect, I invite Dr. Vivek Pakmode sir, our Joint Director Medical Education, Maharashtra State, Joint Director Dental, to express his feelings.
Vande Mataram. Sarvana Namaskar. Good morning to you all. I am really happy and privileged to be here for this wonderful program. It's about microendodontic surgery. Heartiest congratulations to Government Dental College Mumbai. Congratulations and best wishes to Dean Dr. Vasundhara Bhad Madam, Professor Dr. Abrar sir and their team for organizing this wonderful program. On this occasion, I welcome our respected Vice Chancellor Madam, Lieutenant General Madhuri Kanetkar, all speakers, particularly Honorable Dr. Baker sir, Dr. Joshi sir, and more than all the participants across the globe. Thank you so much. Jai Hind, Jai Maharashtra.
Thank you so much, sir. Thank you so much for all your support and those encouraging words here. And I thank our Honorable Vice Chancellor Madam, Lieutenant General Madhuri Kanetkar ma'am, for joining us. And I really apologize to Madam and everyone for the technical delay that we had. To introduce Madam shortly, Lieutenant General Madhuri Kanetkar, PVSM, AVSM, VSM retired, assumed the prestigious appointment of Honorable Vice Chancellor of Maharashtra University of Health Sciences, Nashik, on 1st of November 2021. After 39 years of service in the Army Medical Corps, she is a medical graduate of Armed Force Medical College, Pune University, and postgraduate in MD Pediatrics from Indian Naval Hospital Ship, INHS, Ashwini. She has had the distinction of being first in Pune University in all 3 phases of MBBS. The Honorable Vice Chancellor is a pediatric nephrologist who has done her post-graduation in pediatrics from Mumbai in 1990 and training in pediatric nephrology from All India Institute of Medical Sciences, New Delhi, followed by fellowships in MUHS, Singapore, GUS, London. She has also completed her FAMER fellowship in medical education. The Honorable Vice Chancellor has been Professor and Head of Pediatrics at AFMC and also the Dean at her alma mater. She has over 25 years of teaching experience and was awarded Best Teacher of MUHS in 2008. She has been known to work for students' welfare. Under the leadership, the officers, faculty and staff of Maharashtra University of Health Sciences have undertaken many initiatives in a time-bound manner. These are illustrated in the vision document on the website of the university. For distinguished service, General Kanetkar has been awarded Param Vishisht Seva Medal in 2022, Ati Vishisht Seva Medal 2018, Vishisht Seva Medal in 2014, and she serves as a member on the Prime Minister's Science, Technology and Innovation Advisory Council. With this brief introduction of Madam, I would like to express gratitude from me as a person and department as a whole and an institution as a whole for giving her wholehearted support, personal attention and all possible efforts Madam has made to upgrade this department. This department was established in 2009. Since then, there has been continuous teaching here, but development was a lull. After Madam took over, she included development and upgradation of this department in her vision statement, and she really walked the talk. She has extended all her support and enormous support She has personally cleared all the obstacles for upgradation, procurement, keeping all the things functional here, giving us everything including from the manpower, instrument, equipment and all the support we required. So all of us really thank you, ma'am. So can we have ma'am on the screen, please? I request you to address the gallery, ma'am.
Professor Baker, Dr. Patmode, Dr. Abrar, the Dean of the college, all the distinguished faculty and members who are attending this workshop, a warm welcome to you. At the outset, I congratulate the Microdentistry Department and its head, Professor Abrar, for conducting and organizing this wonderful event. The unit has been doing excellent work, and when I visited first time on taking over as a Vice Chancellor, I saw in it a scope for tremendous expansion and making a difference to a huge number of students and patients. And with that in mind, they took that vision forward in development and organized it extremely well. But I'm happy to announce that the recent decision under the Joint Director as well as the Commissioner of Medical Education to take it a notch much higher and making it a center of excellence with a huge space which we are providing in Mumbai under the university. So the university and the Government Dental College, with the guidance of the Medical Education Department, the Joint Director, the Commissioner, we really hope to see it become a huge go-to place for any patient and student pursuing microdentistry. So I'm sure in the years to come, we're going to go from achievement to achievement with lots of feathers in your cap. I wish every delegate an extremely fruitful academic feast in this conference, which is being organized with some excellent faculty. I saw the program, and I think this is an opportunity. Thank you so much, and Jai Hind. They've dropped out. Professor Baker, I think you're there and I'm there, but I think the line has dropped. Okay, there I
We are there, ma'am. Please continue, ma'am. There was a glitch.
Yeah, there was a glitch, but I have addressed everyone, wish them best, and I'm sure there's going to be a huge academic feast that people are looking forward to, and I wish the organizers, the faculty, and the delegates a great learning experience. Thank you so much, and Jai Hind.
We are thankful and grateful to you, ma'am, for taking out time on such a short notice and supporting us as usual. We hereby display a certificate of appreciation on our behalf to Dr. David Baker. He has taken out time from his schedule and selflessly delivered his address for the gathering today. Thank you so much, Dr. David Baker, and I hope that this association goes longer. And thank you so much, ma'am, for your time. Thank you, ma'am. We now proceed towards the case presentation. Before case presentation, violating the protocol, because Vice Chancellor ma'am was online for a longer time, to save time, we presented her address before Dean Madam's address. Now we'll display the audio message from Dean GD NH Mumbai, followed by the message from our Commissioner, sir, Commissioner Medical Education and Ayush. So may I have that message?
Good morning, our respected Vice Chancellor Madam. Vice Chancellor Madam, our respected Commissioner Sir, our very own Joint Director Dental, Dean Academics, a dynamic HOD, academician and clinician who has shown in this unique concept of live endomicrosurgery from the operating room, international speaker Dr. David, eminent consultant Dr. P.G. Joshi, all the young enthusiastic participants. I, Dr. Vasundhara Patil, Dean of the Government Dental College and Hospital, Mumbai, welcome you all to this unique learning platform. Government Dental College and Hospital, Mumbai is a premier institute established in 1928 and then relocated to the present premises of St. George Hospital in 1962. It is said to be the mother of many dental institutions in India, as most of the senior postgraduate alumni were instrumental in starting postgraduate program all over India. In 2008, Department of Microdentistry was established in collaboration with Maharashtra University of Health Sciences, Nasik, which was a milestone in the history of dental training and treatment. This center bears the pride of being the second in the world after the University of Pennsylvania in US in the field of high precision microscopic learning. It is a methodical training program set since last 15 years with the highest possible skill and precision. I was delighted to see more than 1,300 delegates registering for this program, and that too in the festival season of Diwali. This establishes the credibility of our institution and passion of our professionals towards learning high-ended procedure. I appreciate the efforts of the Department of Microdentistry and congratulate the entire team of Microdentistry headed by Dr. Abrar. Wish you good luck for this event. Thank you.
Thank you, madam, for those encouraging words from you. It means a lot to us. I invite Dr. Wendy Lobo, Assistant Professor, Department of Conservative Dentistry and Endodontics, JDC Mumbai, to read out the Commissioner Sir's address. Wendy.
Good morning to all. I'll be reading out the message sent out by the Commissioner. As a Commissioner of Medical Education and Ayush of Maharashtra, it gives me immense pleasure to wish you all the best for this wonderful academic activity and live broadcast of microendodontic surgeries. I congratulate the Dean, Dr. Vasundhara Patil ma'am, and the Department of Conservative Dentistry for organizing a well-orchestrated program. These microsurgeries on teeth are very high-end procedures requiring immense maneuverability and advanced skills. I appreciate that this department has been the pioneer of developing center for training and treatment of this stature. I welcome the guest speaker from United Kingdom, Dr. David Becker, sir, for selflessly accepting the invitation and delivering his talk on this occasion. I'm sure that Dr. Abrar and his team will be sharing you an academically and clinically fulfilling and enriching experience throughout the journey of this program. I am amazed to witness the enormous response of the delegates across the globe. Confirms the zeal and desire for learning on the part of dental professionals, which will make sustainable progress in the future. Thank you.
With a short formal program, we now proceed towards the clinical case for the day. We have a 30 years old male patient today. Patient currently complains of pain and swelling in the upper front region of the jaw, upper jaw, anterior region. Patient complains that he has had a trauma around 7 to 8 years back. Patient has a scar mark on the lip on an extraoral examination, but that's not contributory to the today's situation because that was in the childhood trauma. 7 to 8 years back, he was hit with a cricket ball. So had a trauma to the anterior teeth, and patient took local medication from a local general practitioner for the same, and it subsided. After around 5 years of the trauma, patient started getting pain and swelling in the same area, and then he sought dental care. Now when you are seeing it on extraoral examination, currently patient shows mild swelling seen in the upper lip region extending from right nostril to the left nostril, superiorly from the base of the nose to the vermilion border of the upper lip. Skin over the swelling appears normal, no evidence of a sinus tract and pus discharge. Swelling appears soft and tender to palpation. Intraoral examination indicates obliteration of the labial vestibule seen between the upper right lateral incisor and the upper left lateral incisor. Sinus tract is seen, swelling is soft, tender and fluctuant to palpation. There is no evidence of parallel swelling or there is no active pus discharge. In the male patient, no obvious extraoral deformity except a mild swelling in the upper anterior maxilla. Clinical examination, there is no sinus tract seen currently here. Teeth appear to be fine except those hypoplastic areas of intrinsic discoloration. Now this is the radiographic picture of the region in question here. You can see that there has been a resorption of the root of the lateral incisor, a large periapical radiolucency, but more than that, we have a mounting challenge of having a huge foreign body here. This patient was residing in a different city 2 years back when he got pain. He went to the local dentist who initiated a root canal therapy. He did not report back to him because of his work. 8 to 9 months back, he reported back to the same dentist again. So he started putting medications inside the root canals at the intervals of 2 to 3 weeks. Such 4 to 5 such visits, the dentist kept on depositing medication here. So not realizing that there has been a gross overextension. There's been gross overextension. So we are dealing with 2 to 3 challenges here. One is infected and maybe a resorbed root, compromised bone, a large apical radiolucency, and this is like a nuclear mushroom cloud, exactly looking like that, a huge foreign body that we need to deal with. Usually people put calcium hydroxide, maybe aqueous, maybe oil based, maybe water based. Whichever you use, couple of months, 3 months, 4 months is enough usually for the phagocytosis to take care of it and eliminate it there. But now this has been there for a very long time. That means the body is not resorbing it anymore. It must have got encapsulated and causing symptoms. So it has to go out. So we will explore this, and an unusual finding as compared to usual inflammatory lesion in these cases is that the lesion appears to be crossing the midline, which is very, very rare for inflammatory regions. So that a suspicion grows in our mind that why did usually, if you see, we've been operating it for decades now, but it usually does not cross the midline. Here if you can see, there is slight flaring of the roots and the lesion crosses the midline. The medication the doctor must have injected has gone up to almost the premolar here. This is OPG view of the same case, lateral incisor, canine, and up to the fore. It seems to be involved. CBCT sections here. This is the lesion, the canal that we need to take care of. Dimensions appear to be reasonable. So it seems worth that the first quadrant lateral incisor should be salvaged. Lesion dimensions are described, 16 millimeter superior inferior dimension. These are the dimensions of the entire lesion and the teeth. If you look at this here, three-dimensionally, you have to go from the central incisor up to the premolar. You can see the bulge because of collection of fluid and the foreign body both. CBCT sections. To confirm the same, we conducted fine needle aspiration cytology examination to rule out anything else if it exists. This is the fluid aspirated and given for histopathological examination. And the report came as infected radicular cyst, differential diagnosis. Another one was dentigerous cyst. Any case, the foreign body has to go in, as it is an infected lesion, it has already undergone lysis. So it needs to be curated, and whatever lies inside need to go for histopathological examination. So surgical intervention was inevitable. We have also followed the case for 2 months, but there is no sign of it subsiding. All the parameters, blood work is clear, hemoglobin, all the blood values, PTINR, BTCT, everything seems to be in place. Patient appear to be physically, medically fit to undergo the procedure. Provisional diagnosis right now, and when we work, is infected radicular cyst with a foreign body. So this was the case described here. Anyone wants to deliberate, question, suggest anything that we need to modify in our approach during this procedure may pose the questions now. Okay? So it'll take me a while, around 4 to 5 minutes to start the procedure. Dr. P.D. Joshi sir is here to answer all our queries if the questions are raised by the participants here. Thank you so much. All to you, sir. This is, they are questioning the plan of treatment. So now you describe, sir, incision kahan se kahan jayega? 1, 4.
All right, friends, welcome again, and we'll be starting the surgery. Dr. Abrar sir is getting ready to get the surgery started. So while he is preparing the patient, patient is already on the chair and getting anesthetized. I would just describe briefly the plan of action. After giving sufficient local anesthesia, we'll wait for about 2 minutes for the anesthesia to work, and the incision would be one tooth on the right and one tooth on the left of the lesion. So you all saw the lesion was from 2-1 to 1-2. So we will be going up to the mesial of 1-4 and distal of 2-2. That would be the location of the vertical incisions, and this would be a trapezoidal incision. So we'll be going either depending upon amount of available attached gingiva, we might be going onto a papillary base incision, or we might go onto a infracrestal incision. So most likely we'll do an infracrestal incision because that looks like a big lesion. Once the incision is made, we will reflect the flap sufficiently to open the entire area. Since we have covered the entire lesion in the incision, we will be able to see the entire lesion right underneath the flap. And then we will open the area by doing some osteotomy so that we can curate the lesion, and we'll be curating the lesion with different types of curates, and you will be seeing them live while we are performing the procedure. At the same time, once the lesion is curated, we will remove the tissue. We will put it in any of these, either saline or formalin, for the pathological investigation, and then we will go for resection of all the 3 roots, and we will be doing retrograde preparation with tips all under microscope, and you'll be able to see live. And then we'll be placing bioceramic putty or MTA into the apical 3 mm of the canal, and then we'll be giving finally microsutures to close the flap. So Dr. Abrar seems to be ready. Whenever you're ready, Dr. Abrar, we can turn the camera to you. Okay. Describe.
We are administering mic to me. दादा चश्मा गिरा रहे, कैसे उठा रहे? उठा बेचारे को। ये बेटा इसको उठा।
Hello, 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 hello.
Adar ele. I have just now administered infraorbital nerve block. Now I will be proceeding towards the greater palatine vessels here. You can see it on the screen that I am entering the canal. यहाँ प्रेशर आएगा, यहाँ प्रेशर आएगा भाई, पेन होगा थोड़ा सा आपको, बस. These injections are usually painful for the patient. The rest of them will be practically painless. I am inside the canal here. We may not be able to deposit more than 0.2 cc or 0.3 cc of the solution. It's always important to anesthetize greater palatine vessels. Full. Full. Loaded full. We have given inferior alveolar, infraorbital block on the right side of the maxilla. Now we are proceeding towards the left side because we are raising a flap. अब तक आया ही नहीं कुछ माइक्रोस्कोप पर, क्या कर रहे हो? Give me cotton please. Am I audible there? But video feed has to go. When the video was not available, just to inform. Okay, fine. We're back on the video. बंद करो गूगल. हाँ. We are administering local anesthesia on the left side of the maxilla. क्योंकि दुखेगा नहीं है इतना, इसमें दर्द नहीं होगा, आप नहीं घबराओ, इसमें दर्द आपको नहीं होगा इतना, ठीक है? Loaded LA new needle. Gentle rubbing to dissipate the solution into the tissue spaces. It is always better to have generous amount of anesthesia here. It not only gives you anesthesia, it gives you very good hemostasis. Along with the hemostasis, it ensures that the different planes of the tissues get separated. Now to deposit anesthesia locally into the anterior maxilla, I am going in and injecting during withdrawal so that I don't have to take multiple pricks. I go into that same area. Suction please. Before we start the actual surgical intervention, I would like to declare one thing, that he is a 29 years old young healthy male patient having enormous amount of granulation tissue in the anterior maxilla. As all of us are aware, बेटा ठीक है ना, आराम से बेटा, कुछ नहीं होगा आपको, एकदम रिलैक्स रहना. बंद कर. टीवी को ऐसा ले लो, इधर रखाओ टीवी, मैं देख के टीवी में काम कर सकता हूँ. बेटा अभी खत्म ना आपका टेंशन, ठीक है? अब एनेस्थीसिया दे दिया आपको, अच्छे से एनेस्थीसिया काम कर रहा है बेटा, ठीक है? इज गुड बेटा. लेवर्स फील्ड, हाँ? What I'm doing here is gently massaging the tissues so that the solution gets dissipated well. Most of the swelling that patient gets post-operatively is not because of the procedure per se, not because of the curettage, not because of the reflecting of flap. Mostly the swelling comes as a response to irritation caused by deposition of the local anesthetic solution that adds potentially to the edema. And this kind of massage, gentle massage, will ensure that the LA is not deposited in a specific location, but dissipates itself into a wider tissue area, giving us a hemostasis. And most importantly, in all surgical procedures, it gives us excellent tissue separation that will help us to separate the tissues. And mind well that this is a live surgery. This is through a microscope. We will be going out of focus many times. The moment I move a little bit of the patient, except when there is instrumentation happening, the screen will appear to have swiveling. Okay, so don't feel that something is getting discontinued or something, but that is inherent in all microscopic procedures. So now here, it's a good habit to mark the incision where we want to take it. In this case, better mind your head, mind your hand, okay? I am looking in the scope. So our lesion goes almost up to the canine. So one or two teeth distal. So I may go up to distal of the 4, okay? Distal of the 4 I will go. And here if you see, there is a very, very tight muscle attachment, which I will avoid cutting off, okay? So this is my distal extension of the incision. And here we will take distal to the 2. This will be location at the line angle of the tooth to preserve the papilla. We have been traditionally taught to take incisions with a flap wider in the base and narrow at the apex. However, in anterior maxilla, angiographic studies have proven that the vessels which supply run linear direction. So we in endodontic surgeries prefer to take these linear lines, okay? So to begin with, we start our incision here. You angulate the blade as the tooth anatomy permits and the attachment, and you go deep, touch the bone and gently start separating the soft tissue. They are distal to the 2, and remember, don't make frill of the tissue. Be very confident of separating and cutting the tissue and touching the bone. Walk the tip of the blade onto the bone. Here is the lesion, lot of bone loss. So if you can see, my BP is sinking. Suction please. Respect the anatomy of the tooth when you raise a flap. Suction please. See, there is a cervical lesion here which may misguide us. This is to avoid any untoward cuts, because your hand may slip because of a tooth contour. To be very careful and respectful. See, the microscope tells us all. It doesn't hide anything. It acts like a mirror. That's the beauty of working with a scope here. You are seeing this at the magnification of almost 12 to 15. Going between the central and the lateral and separating the tissue. You see the stroke, separating is important. I'm intentionally not preserving the papilla completely horizontally. Vertically, yes, we have followed papilla preservation on both releasing the design. This is very tight. Be careful in instrumentation, very careful. As I said, unless the tissue is dictating and talking to you to sever itself, do not give repeated cuts. Dr. PD sir is here with us, guiding us. Canine has an amazing contour, so respect it. Being endodontist gives us an edge on this, because we understand the root morphology. So we end separating them well. Go interdentally and separate. And once from here separate. Wait, I'll do that. I'll do that. Pulse ox लगाया ना इसको? Pulse ox. We've gone up to distal of 4 and now we are taking a releasing incision. You have to either include the papilla completely or exclude it completely. Here, as I said that we take linear incisions in the endodontic surgeries. However, I am taking it a broader base. Not because of that fact, because of the muscle attachment. Okay, as David Baker also mentioned that there are few basic principles of flap design for endodontic interventions. Not to horizontally cut or sever a muscle attachment. Okay, so now I want to once more verify that I have separated. Yes, I have separated. Suction please here. I'll focus the microscope. Beauty of the microscope is that every time you view, you change a viewing angle. See, this has got raised beautifully here and here. If you can see, there is double incision. You have to magnify a lot to show it to you. As I told you, microscope will not lie. You can see a double incision, very small. Yeah, this should not happen here, okay? And I will just verify that I have separated all the interdental papillas. The moment I verify that, I will proceed with reflection of the flap. We are at the magnification of 25x now, highest magnification. See this, the tissue separation is complete and I check it here. The tissue separation is again complete. Yes, it is complete. We are likely to get a tear in the flap in the maxillary anterior region. Because of two factors. There is a buttressing bone formation because of occlusal alignment. So that gives us a very rough terrain to work on, a very rough contour of the bone to work on. Secondly, so to begin with, I have now focused the microscope onto the smaller one. I am not using the micro instruments right now because our lesion is big and those sizes are required for single tooth, and though we have the armamentarium. This workshop is for general practitioners and learners. Raised it, separated the papilla first. Now I've gone here again to the canine, raised it, got separated. See, there is adherent granulation tissue has reached the gingival attachment. So we are likely to see a buccal complete lack of bone. CBCT is a very, very important guiding tool, but in my personal experience, CBCT in apical surgeries, if you considered, which are microscopic, many times it overstates the bone loss. Many cases I see there is clear nasal perforation. Okay, I am ready myself to suture the nasal mucosa. We in endodontic, when we do surgeries, we are very scared to open up the sinus or the nose. And working with the Department of Oral and Maxillofacial Surgery in Government Dental College, under their guidance and support and help for so many years, now I understand that it just requires to be sutured. That's it. Even if you open up the nose or the sinus at times in endodontic surgeries, there is nothing to be panicking about. Okay, if you're clear of the diagnosis, there is no massive separation in the sinus, or you are not likely to create any fistula, you can immediately take up the suturing material and suture it out and proceed with your work. I am not getting full thickness mucoperiosteal here, central and lateral. So might have to raise the way I get it. Because of continuous resorption and deposition at the periosteum, there is tightness, there is destruction, there is resorption, there is remodeling, everything happening at the same time because cysts are expansile. They create these problems for us. Now, I am inserting a gauze. The gauze is going to help us to raise the flap in a blunt manner. You see, I had told you this is the challenge. You can see buttressing bone formation happened here. That's not allowing us to release. Yes, this is a very tight attachment. You see this muscle? You can see this muscle I'm separating. Yes. Oh my. Directly opened up into the lesion here. That's why it is so adherent. You can see that lesion I'm opening up directly. Okay, sir. I'll take that, sir. Thank you, sir. Sir has given me a very good suggestion to take a releasing at the lateral again. So, with sir's permission, I may first raise this enough and then take that call. Thank you so much for your guidance, sir. Need to release the 4 a little bit here. Need to release the 4 a little bit here. The releasing blade. Not to separate the deeper tissues or to affect any muscles in that area. We have to be extremely careful. See, this is attachments. As I told you, once you palpate this bony contour, one has to be extremely careful. You should see the periodontist and the surgeons working here. Amazing. Because that is their daily job. This is the lesion we need to take a jump into. We will not dive into it right now. We will first raise our flap. Adequate access is of paramount importance here. इथलं रिलीजिंग दिलं पाहिजे ना आता लॅटरलच्या करता रिलीजिंग आपण दिलेलं नाही हां हां we have been working for a few minutes now. We are putting saline into the surgical area at the flap to hydrate the tissues. Great. Thank you. We are hydrating the tissues. Saline beta. Distal to lateral incisor. By that time, I will take an incision here. Turn, first turn करा. unable to raise, separate नहीं हुआ है ना? Suction in this area, it is not getting separated. Bony contour has got some fibers here which are in the undermining area, so they are retaining the flap. I'll raise the flap and show you the contour where the flap has got stuck. If you are witnessing, I'm unable to raise the flap because of the contour of the bone. Be very gentle here. Yes. In this area, this attachment, yes. This is a lesion, encapsulation. Sir is there, na? Sir है ना? Sir को बैठने चाहिए. You can see these are the boundaries of the lesion, and this is the papacious bone. Now, what I have observed over the period of years, a distinct difference between us and the surgeons. Because of their excellent surgical skills, they would immediately start drilling and remove this buccal cortical bone and save the time and remove the lesion in toto. But what usually we do, and endodontic specialists, we first remove as much as bone possible through not drilling it, try to locate the roots of the teeth involved, and then go ahead. Superior attachment here, this is the lesion, this is the bone. It has eaten up bone almost up to the margin, and this also is involved. This whole thing is involved, and there is a foreign body lying here. What I described as mushroom cloud of a nuke. It looks like that. If you see, I can got punctured. You see that fluid? This is the fluid coming out. This is the content of the cystic lesion, and this is the bone we have to remove from here. First, tracing the extension up to the lateral incisor distally, the second quadrant. हाँ, नाक से सांस छोड़िए थोड़ा सा, जुगल, नाक से सांस छोड़िए. There are no bubbles coming. That means there is no direct pulpal nasal perforation. As we remove the bone and go inside the lesion, all you will see is oozing and blood, because he is a young patient having a lot of granulation. We call it cystic lesions because we want to call them, or we want to declare larger lesion as cysts. But the classical study of Nair et al. In 1998, after that the perceptions have changed. It is never a purely a cyst, or it is never a purely a granuloma. It can usually be an interplay of both of them. We need to remove this much of cortex here to access this foreign body, which is large. If you break it in pieces, it will be very difficult to remove it because of the cortical erosion on the palatal side. So usually we don't like to drill at the initial point, but in this case we will have to take a punch cut here, and a linear and a horizontal transverse line here, so that right now I open only this much of the tissue. If I can access it inside here through this much of window, this is a natural cortical window given to me, and this is the excessive bone beneath which or deep to which lies the foreign body. So may I have this working, the micromotor and the coolant, please? Yellow button. Okay, thank you. May I have the coolant, please? वाढवा, थोडंसं वाढवा. See, I did not have to cut much of the bone. This was thin papacious bone exhibiting typical eggshell crackling. I can see that calcium hydroxide, mostly it is yellow in color. See, this is the root apex of the central incisor, and you can see the foreign body. Let us first clean. Okay. We'll give the patient a break. Break ले लो आप आराम से, हाँ? करें. Yes sir, yes sir. हाँ सर, आप नहीं, but you are at the end of the. तो तकलीफ नहीं ना, आराम से बैठ. I would like to mention one thing to all of you. When you work in anterior maxilla, we have anesthetized the upper lip of the patient. हाँ, आप मुंह बंद रखिए, आराम से आराम. Suction डालो बेटा. We have anesthetized the upper lip completely bilaterally. We have deposited a lot of solution in the tissues that gives a swelling, and that gives anesthesia not only in the inferior part of the nose but also to the lower eyelid and lateral part of the nose. So patients usually fail to feel the friction of the air going in. So that at times, heightened by anxiety, it can give a feeling of choking to the patient. Secondly, when you retract continuously, the upper lip may block the nostril. So remember that never retract both the sides of the lip together. Whichever side we are working on, that should only be retracted to avoid closure of the nostrils with the lips. If that happens, if you affect the ventilation for a longer time, patient may have heightened anxiety and go into increase in blood pressure and increase in oozing, or at times other problems with increase and heightened anxiety of it. You're okay? चालू करूं वापस काम? Okay. आप आराम से बैठो, कुछ नहीं, चलता रहेगा. हाँ? Always keep the teeth hydrated. Never ever allow the teeth or the flap or the bone to desiccate. Desiccation can have deleterious effects on the whole procedure. ठीक है ना? Today. Going back to the same work again, we were cleaning off this tissue. There are tags, so there has been resorption of this root along with this. This is not a healthy bone. Okay, this is not a normal cortex, and the spongosa would look like. So there has been a replacement resorption, actually a dehiscence here. Okay. This is the condition of the central, which was looking healthy in the X-ray and the CBCT. Lateral, we are expecting to be even worse as far as the resorptive part is concerned. Suction beta, this side suction. Yeah. Yes. We have exposed the root of the central incisor already. Now we need to go in and expose the root of the lateral incisor. You have a mic. You can talk now. You can talk now. I'll complete.
So I'll be describing the procedure till now. Dr. Abrar is now in osteotomy to expose the whole lesion. You could see that he took a.
Give me on the tip.
intrasulcular horizontal lesion and not the papillary base. When you have such a large lesion and when the lesion is very close to the neck of the tooth or cervical margin of the tooth, you don't take papillary base incision because you don't know, maybe you might encounter the gingival area. Secondly, the plenum attachment is very low. So again, there it requires to have certain amount of high plenum attachment to attach the gingiva for taking this kind of horizontal incision. So this is helping us to expose the entire lesion and gradually we uncover the entire floor of the lesion through osteotomy.
Direct. कुछ होता है? ठीक. So, irrigation, coolant. So you all can see here that I have this is the capsule. This is the capsule. थोड़ा pressure आएगा और pain होगा. No matter how well you have anesthetized, in local whenever you work, this stage patient is likely to experience pain. This is the lesion I am trying to separate, and it is in continuation. I show you the CBCT. This is in continuation with the all foreign body. You can see this is left central incisor, root apex. The GPs are out. We have exposed the upper left central incisor, apex of the 2-1. The area which I am entering now, I am likely to encounter an oozer there, a bleeder there. You can see the GP point, a small GP point in the center. This is the GP point. As I told you, there will be a lot of oozing, so nothing on the screen as such for you to understand. Microscope tells me a lot of things. See, this is the first increment I am taking out. This is that, yes, you can see that tissue. Can you see that? Please tell me in the comments, because color distortion may happen in the YouTube. It is totally encapsulated. See, this is the outer capsule of that cystic lesion or granulation, okay, beneath which lies this suction here. You see that? Yes. So I दुखता है आपको? अंदर जो चीज़ है ना वो हिलता है ना, तो थोड़ा सा दुखता है. बाकी आपको कुछ तकलीफ नहीं होगा, आप फिक्र नहीं करना. आप ठीक है ना? आप रिलैक्स रहिए, चिंता नहीं करेंगे. चलो.
A little bit of local inside the lesion itself.
Yeah. Yes.
To reduce bleeding and also.
Sir. Sir, उधर पूरा calcium hydroxide is there, no? So I'm not injecting. Give it right away. As the patient is getting discomfort, we are anesthetizing. We are depositing some amount of anesthesia inside that lesion. Suction please here. Is likely to taste it bad. रिलैक्स भाई, कोई तकलीफ नहीं ना? हाँ, आराम से बैठो, आराम से. आपको ब्रेक लेना है तो बोलो, पानी पीना है तो बोलो. नाक पकड़ ले रहे हो, नाक से सांस ले रहे हो. पहले लेना चाहिए ना. हाँ. Will we give him a break? Yeah, we'll give him a break. We can kill the screen for around 3 to 4 minutes. We'll have to give him a break. As this is the live surgery, we can't hasten any procedures. As we are curating out the inflammatory tissue lesion, this inflammatory lesion, whenever it causes any pressure and movement, it will cause pain. So we are forgetting and continuing the cooperation we have so far received from the patient. We have given him a break for 3 to 5 minutes. We are killing the screen and the audio for a few minutes.
Give a local on the base all around and inside the
हाँ यार, तुम नहीं कर सकते यार.
at the depth of it.
कैसा जा रहा है? कैसा जा रहा है? How is it going? Scientifically कैसा? ये आपको बुलाया, गुरुजी को बुलाया. अरे गुरु को, बाकी हम लोकल लोग को बुलाते, तेरे को हे सगळं कुठेतरी रेकॉर्ड होतंय ना? Hello everyone. The lesion on CVCT is extending from 1-4 to 2-2. The maxillary right first premolar to maxillary left incisor, lateral incisor. So lesion being quite large in the dimensions and the local area has been irritated by presence of a foreign body, and the diagnosis came out to be infected radicular cyst because of the pus discharge and because of aspiration cytology results. It is not a good bed for us to graft the bone in this case. However, to expedite the healing process, you can take, yeah, start the video, no problem. So to expedite the healing process, we have a plan to use PRF for students who have not performed or seen or experienced drawing the blood and making the PRF. Dr. Priyesh here, who is an observer, we welcome you, Dr. Priyesh. Just say hi, us. Dr. Priyesh, maxillofacial surgeon. So he is drawing the blood right now. As we have given the patient a break, we are drawing the blood for making PRF. So after we clean the lesion, we go, first of all, current priority. Right now we have opened up the tissues, we have made punch cuts, we have removed the buccal cortical plate, we have severed the attachments of the capsule to the tissues which are undesirable. So in a way we have isolated the lesion partially from the inferior border and the buccal border, buccal outline and the inferior. So now after this, after the patient becomes comfortable, we will go towards the superior attachments and then finally the palatal bone, because we don't want to perforate the lesion. As I have palpated it, it does not seem to have perforated in a large manner on the palate. So do not perforate the palate. We can support the palate with one finger and touch the curette to your finger and gently dissect or separate the capsule of the cyst from the lesion, from the periosteum there. Okay, though it is perforated, though it is complete cortical erosion must have happened, the mucosa must be directly, submucosa must be directly resting on the periosteum. We have to gently curate it palatally. So being such a large defect, we are right now drawing the blood to use centrifugal machine to make the PRF. Can we have the camera on the drawing of the blood? Dr. Priyesh drawing the blood for using PRF. In the frame we have Dr. Reshma. No, ha camera. Dr. Reshma, maxillofacial surgeon, has been assisting the case throughout and she has taken a lot of effort to organize everything. We are thankful to her. Dr. Shaili Mehta with her, second assistant. She has completed masters in conservative endodontics from the same department. And Divya, postgraduate student, who has managed the whole case. You can see all of them in the frame right now. Thankful to Dr. Prachi, who has communicated to all of you for making the WhatsApp group. She specializes in oral maxillofacial radiology, oral medicine. And Dr. Wendy, who read out Commissioner Sir's address here. This was a team who very actively helped. I thank all the other staff members, Dr. Kishore Sir, Dr. Manoj Sir, Sangeeta Madam, and everyone else, and Dr. Jyoti Wankhade also. Thank you everyone. We are drawing the blood. After the draw of the blood is complete, we will start the procedure back again. Can you focus on the range वरती focus करतात इथे का बघा. Yes. मायक्रोस्कोपचा लाईट बंद कर बेटा. चेअरचाही बंद कर, पेशंट तोंडावर उगत लाईट आहे. हे बंद कसं करायचं? हे बंद कसं करता तो? मी ऑफ किती करतो? सध्या ऑफ करा. आपले साधे एक्झामिनेशन ग्लव्स आहेत का? कुठे? चल, पानी पी लो, धंधे पे लग जाओ. If you can show them, you are on the camera. Yeah. Five ml of blood which was drawn is being placed inside the machine. अगर आप एप्रन पहनने हो ना तो मुझे बार बार समझ में नहीं आ रहा आप किधर हो. आप समझ रहे हो? नॉट यू. अरे किधर गए? That's why I'm asking the review, sir, किधर है? इधर ही. हाँ सर, प्रॉब्लम क्या है सर इधर? अगर वो टूट के डिसॉल्व हो गया ना सर तो आधा घंटा लगेगा. Why we are delaying the surgical intervention so much here, and why we are, it may seem that I'm beating around the bush. I'm not directly entering into that foreign body. See, the foreign body is not a single solid crystal. Foreign body is an amorphous material which is a powder. On करून टाका microscope चा. Take the microscope live feed. Yes, audio is on. Okay, so what I was saying that the material which is lying inside the maxilla is not a single piece crystal. It is an amorphous material which is calcium hydroxide, and that too dehydrated. So if I try to make haste here and directly break the conglomerated mass, then I may cause a spillage over the tissues. So I have to keep on removing it piecemeal, small pieces of that material, almost an hour's time. So what I have decided as a plan is to first of all isolate, retract all the lesion from every end, and then try to remove in a single go as much as possible, rather than, because calcium hydroxide, if irrigation is used, may dissolve, especially if it is aqueous based. Probably this is silicone oil based calcium hydroxide for sure. Now after isolation, after retraction, the color scheme is different here, the color balance is different. This is a distinct yellow color here. If people can see, yes, this is a distinct yellow color. I'm not going behind it right now. Yes, see this. This whole thing is moving. This is the capsule of it. Yeah, this is what I'm surrounding it with. It is now likely to come out in toto. Hey beta? Yes. Because the dimension is large. Yeah, if all of you can see what I was talking, it as much as I can get in one piece. Yes, this is what was desirable here, to get that foreign body in one piece. Okay, may I have something to hold? Yes, tweezer. This was the culprit. I have removed, and now use smaller pieces, and now use a surgical scoop or a good old time curette. Nothing works as a curette like a curette in the periapical surgeries, believe me. Amazing instrument. You can see the overextension. Don't keep any solution here, it will dissolve. What is the solution? Saline mein. Yes. See, this is the gutta percha, overextension gutta percha. This is the root apex of the central incisor. And now I want to go towards the lateral and now curate this. This is the capsule of the lesion, which I need to separate from the mucosa and the submucosa artery, blunt. Now we'll perform some blunt dissection of it. जो अंदर प्रॉब्लम वाला चीज था ना साहब, हाँ, निकाल दिया उसको. हाँ, अभी अपना काम आराम आराम से चलेगा सफाई का। हाँ, अंदर से पूरा साफ करेंगे फुर्सत में बैठ के। हाँ चलो, तुमको प्रेशर लग सकता है बीच बीच में, हाँ आप घबराना नहीं, उसमें प्रेशर लगेगा तो सिर्फ हमको बोल देना, तो हम लोग रुक जाएंगे अगर पेन होता है आपको तो। सक्शन प्लीज इन दिस एरिया। लेट अस रिमूव दोस पीसेस ऑफ द मटेरियल फर्स्ट। आराम से, इधर दुखेगा हाँ भैया थोड़ा सा आपको। Hele please, hele please, hele please. This is the distal extension of the lesion on the maxilla. He is getting pain here, so I need to give him some anesthesia here. And not to work in that area just for a while, okay? Let the anesthesia which was administered just now take some effect, and let's think of handling and removing the main granulation from here, or capsule, whatever you call it as. So the GP is flanking itself out of this root apex here, and this is the foreign body, and this is the root apex of the lateral incisor, okay? या प्लीज प्लीज, आपको चश्मा पहना देता हूँ, पानी नहीं उड़ेगा आपके आंखों के अंदर। हाँ जी, द प्रोटेक्टिव आईवेयर इज बैक ऑन द पेशेंट्स आईज। क्यूरेट द बेटर वन, दिस इज द वन राइट। हाँ दिस इज द वन। चलो 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 चलो, सक्शन। नीचे देखिए थोड़ा सा। हाँ, इतना नहीं होगा पेन, आप नहीं घबराना, ठीक है? जस्ट रिलैक्स थोड़ा सा। अक्षर अंदर चलो बेटा। See, this is the granulation tissue having entangled, this tissue has entangled the foreign body. This is a foreign body reaction on the body's part. अभी भी बहुत है रे। Okay, okay, चलो। Suction please. Wait, I need to take out these debris first. A lot of debris here, see this. Yes sir. Yes sir, yes sir, yes sir, yes sir. Hey, wait. What was this? Okay, this is the mesodense.
Okay.
Relax. Okay. This is the... जी अच्छा कर रहे हैं आप मुझे बता दिए, मैं अभी ध्यान रखूंगा। We have just now taken out a mesodense tooth. You see that in curettage that was existing in the pre-op CBCT, and that was there inside the lesion. Suction. Yes, after removal of pathology from there, we would like to go for the root resection that gives us an axis. See, grossly we have debrided it. थोड़ा सा इधर हिल जाओ आप. हाँ बस. सक्शन डालो बेटा अंदर. हाँ और ले और हाँ मटेरियल आ रहा है. रुको अंदर बहुत मटेरियल है अभी. Remove it first. हाँ रुक जाओ बेटा. See, this is the material. Taking out everything from there. Material and lots of it. Chalo, root resection. Sir, root resection handpiece. Earlier we used to use the straight fissure. Nowadays these specially designed handpieces are available that help us see the design. Old days we used to use this one. Okay, old days we used to use this one to go and resect the root, but that did not allow us an angulation. P.D. Joshi sir was gracious enough to share this with us. Sir, burr. This is how you get a burr with it. Okay, this is a specialized burr tapered with flat end for apical root resection. Compressor is on. Sorry. Microscope light has gone. Yes. Always have someone else also help you to assist the direction. Sir, Dr. Reshma, is the direction, sir? Direction of the resection is correct? Reshma, retract here, please. Yes, yes, this is a good. Sir, is the direction correct? Am I? Suction. Oh, there is still a lot of material inside that I have to slowly go and remove, and this attachment. Yes, sir. Thank you. Thank you so much, sir. Now I go remove the capsule attachment from palatal aspect of the lateral incisor. But you don't retract, I will retract. Now I am going to, yes, see this is ऐसे उठा आराम से बैठो. हाँ भाई, चलेगा काम फुर्सत में. And then go to the lateral incisor now slowly. Bigger retractor, wider retractor please. A wider retractor, yes, still wider. I have a very wide retractor. I want to resect the bone, so I need better isolation there. जी, कोई दांत नहीं निकाल रहा है. अंदर का छोटा वाला दांत हमने निकाल दिया दादा, जो अंदर था. बंद करो, मुंह बंद करो आप. कुछ नहीं होगा, मुंह बंद करो आप. मुंह बंद करो आप थोड़ा सा. हाँ, बंद करो आप, बंद करो. हाँ बस. हाँ, कूलेंट इज रिक्वायर्ड. हाँ कर, रिलैक्स. बंद करो आप. समथिंग हैज हैपेंड। दादा रिलैक्स हो जाओ, कुछ नहीं हो रहा। साइड ले लो, साइड ले लो। हाँ चालू रख रहे, चालू रख रहे। दबाया हूँ बेटा, फुल दबाया हूँ। हाँ थोड़ा बंद करिए। हाँ कूलेंट प्लीज। थोड़ा मुंह बंद करिए सर। रिलैक्स हो जाइए, रिलैक्स हो जाओ। थोड़ा ही काम बचा है, आप रिलैक्स हो जाइए। थोड़ा सा आपको कोऑपरेट करना पड़ेगा। यहाँ पे आपको बताया था ना मैंने कि एक जगह पे पेन होगा, वो इधर ही होता है। यहाँ पेन थोड़ा तकलीफ होगी आपको यहाँ पे। हाँ जी। बंद करेंगे थोड़ा। हाँ थोड़ा बंद करेंगे। जुगल 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 जुगल, हिलना नहीं। मुंह बंद करो। Still there is a lot of foreign body material here. चलो जुगल जी हिलना नहीं आपको। This is where he is likely to get pain. Suction. This is the material coming out again along with the tissue. The material is so much entangled in the tissue that you can't separate both of them. I have to scrape off. Suction डालो अंदर. Scrape it off with this. It is totally encapsulated. Pieces of the material are encapsulated. Suction. Suction is very slow. Suction inside. हाँ बेटा, नहीं कैप्सूल से पूरा दुखता है इतना, रिलैक्स हो जाओ, रिलैक्स हो जाओ। चल बेटा डाल सेक्शन इधर। See, this is the tissue, this is the lesion. I'm dissecting it from the palatal aspect, and he's getting pain because of greater the nasopalatine. But you will dissect section. He will get some pain here. For the tissue. Section. रख इस पे, हाँ. Put it here. Yes. Yes, this is the scenario inside. You barely see the bone. There is still a lot of lesion inside. And this is the capsule of the lesion. I am separating it out. He is getting pain. Patient is bound to get pain at this point of time. You need to gain some cooperation and complete this. We have hit an oozer. We'll wait for it to subside. Huh? Sir, we'll take over taking. You want to take? क्या हो गया ये उसका it is not sealed, that's why we are losing the suction power. Rajendra, close the lid of the suction properly, that is why it is not suctioning well. You have to push that lid inside properly. ना टाइम लगेगा भाई, आराम से करते बैठूंगा इसको, आप समझ रहे हैं. रिलैक्स हो जाओ. ये पार्ट थोड़ा पेनफुल है, आपको बताया था ना पहले भी. एक पार्ट आएगा वो पेनफुल रहेगा थोड़ा, ये रहेगा. आप थोड़ा इसको एक्सेप्ट कर लेंगे, थोड़ा हम लोग साथ में काम कर लेंगे. 5-10 मिनट लगेगा, थोड़ा पेन का पार्ट फिर ख़त्म हो जाएगा ना, फिर हम लोग दांत बचाने के प्रोसीजर शुरू करेंगे. समझ रहे आप. अभी तक क्या किया हम लोगों ने, इसको ओपन कर लिया. फिर क्या किया, देखो वो बड़ा ऐसा ये निकला ना, पत्थर टाइप, कंकर टाइप, वो निकाल दिया पूरा अंदर, जो आपको दिखाया था एक्सरे में. अब जो है उसके अतरफ है ना, ऐसा एक कैप्सूल रहता है, एक कवर रहता है बड़ा सा. वो कवर जब हटाते हैं ना, वो नहीं हटाएंगे तो वापस हो जाएगा. यही प्रॉब्लम आज नहीं, 2-3 साल के बाद हो जाएगा. तो ये कवर थोड़ा दुखेगा, लेकिन उसका कवर पूरा निकालना चाहिए बाहर. वो एक बार निकल गया ना, फिर हम लोग दांत बचाने के लिए अलग ट्रीटमेंट शुरू करेंगे. तो अपने को टाइम आराम से लगेगा. हाँ, फिक्र नहीं करो आप आपको कुछ नहीं होगा. आपको जब भी ब्रेक चाहिए बोल देना, आराम से करेंगे इसको. जी हाँ, ही इज टॉकिंग, वो दे दे, सक्शन दे दे उनको. चलो, हाँ, प्रेशर पैक सक्शन ले बेटा, बंद करो बेटा. What solution? Huh? Which one? Ferracrylum. I am packing a gauze saturated with ferracrylum here inside the lesion to achieve hemostasis. This gauze has been saturated with ferracrylum. This will give me better visibility. As I had declared initially that we are going to have this problem of oozing for a long time. बाबा कुछ नहीं, आपका अभी कुछ काम नहीं चल रहा है. हाँ, अंदर सिर्फ कपास डाल के रख दिया है. काम चलेगा तब बोलूँगा, थोड़ा सा दुख जाएगा आपको तब. ठीक है. What we curated out, finish. Because hemostasis करके भी ultimately we are going to take it out. Yes, thank you, beta. A lot of it.
Hello, Dr. P.D. Joshi again over here. I've been looking at the chat. And there's one comment by Dr. Sudhir Jagannathan. We appreciate your comment, sir. And you said that it should have been done under IV or sedation. You are absolutely right. In a normal course of time, we would have taken the patient to OT and done this procedure, but it wouldn't have been possible to use microscope over there to show you so much live to such a vast audience from the OT. We can't have so much of gathering of the cameras and screens and everything around in the OT that easily. So that's why we decided to do it under local anesthesia and go slow over here. So I hope that answers your question. We are not disputing you with your query, but we are also justifying that we are doing over here in the department. I hope that answers.
Yeah, I would like to.
Other question or comment, you can just put it on the chat. We can answer at this point in time.
नीचे देखो बेटा. I would like to add a few things to the same.
Yes.
That these lesions have a very brief period of some kind of discomfort to the patient, very brief. And I think if your patient is ready during a conversation, I had given him an option of the same. Patient said if I have to bear some pulling sensation for a while, is better than taking any sedation.
Absolutely. The patient comfort and patient's own preference is also important in this case.
थोड़ा नीचे देखिए. This is all the debris which are entangled on the palatal aspect and very adherent. This is going to take some time for me to cure it out. So these are the, you can see that this soft tissue is impregnated with all the you have a chunk of the tissue and the foreign body here to remove. 1 minute, 1 minute. Yes, very nice. Keep the suction there. I want to see where the lesion is and where to get the. Yes, this is again a piece, a chunk. Wait. Very adherent tissue on the palatal aspect of the central and lateral incisor, not coming out, very stubborn. You can see I am dissecting by all means possible. I need sometimes I do this with a spoon excavator, a small spoon excavator, because these intricacies are very small in dimension. I'm been able to take out some tissue, not complete yet. This takes quite some time. Okay, in a normal course of surgery, peacefully dissecting the palatal will take around 20 to 30 minutes time, only to correctly remove the palatal adherences. See, there are still foreign body particles here, big in number, in even size, adhere to the root surface. I will have to expand the opening a little bit here. Coolant, please.
Coolant, please.
See, this is 1 minute, by 1 minute. बस हो गया बस 2 मिनट and slow process has to be followed. Periculum causae.
Yes. Okay, I'm replying to some more queries online.
Sir.
The question is by Sarvari Deshpande. Is it advisable or recommended to irrigate such cavities during curettage with saline especially in this case to help get rid of chunks of foreign body. Yes, we have been doing it continuously, simultaneously along with,
And to add to sir here that we did not aggressively irrigate because there was no counter area of exit. Irrigation would have been helpful to dislodge and debride it out of the cavity if it had path. It did not have a path. The entire foreign body is encapsulated. That too discreetly encapsulated into different areas. Couple of chunks were there which I could remove, but there is a lot of other areas where it is still attached. So as we understand and imagine on the X-ray that there is a single clearly outlined foreign body sitting there, I'll go and scoop it out, does not remain a possibility here. There are big chunks, smaller chunks, very smaller chunks, and then individually encapsulated and adhered to the bone. So that we have to go slow into it. You will proceed. Please, glove. Chalo. For better visibility, achieve hemostasis like this and have a look. See, ji, हाँ sir.
Giving local anesthesia 1 hour before, it will not work. Have to give about 5 to 10 minutes before the procedure. So current nerve block work only on the parietal part, not so much on the buccal part. So it still needs the intraorbital nerve block which Professor had given.
And the opening of the nasopalatine duct on the palate is a very specific angle, which I showed you entering it. After you enter it, even if you enter it and deposit the solution, many times this is the only area where the patient is likely to get some pain. Okay. After that, patient will be very comfortable. You actually perform the apicectomy and retrograde cavity preparations. So I have curated most of the lesion. See, this is one area where I'm not able to reach. I can reach easily if I destroy the root. I don't want to destroy the root because he'll lose the anchorage. The patient is very young. I want to save his teeth as far as possible. So this all hard work and time is being spent to save this root. We are working around the root. You must have noticed we are working around individual root. We have not destroyed this root. Easiest way is to cut this root and remove the lesion. Surgery is not to cut the root. Surgery is being done to eliminate the lesion which is not healing and resorbing on its own. So to be conservative, we have to be very patient and go very slow. See, I'm touching the palate, and here is the perforation in one area, and see this is the bone. This parietal bone, this is the area of perforation inside. I can feel the. Over to Dr. P.D. Joshi sir for apical root resection and retrograde cavity preparation. I am packing the lesion with ferracrylate solution for achieving a good hemostasis here. भैया pressure लगेगा थोड़ा, हाँ चलो आ जाओ. Back is hurting. Try to discard now, please.
We're answering some more questions also while performing, so if you have any questions you can ask me. Okay. Yeah, go.
Be used here?
There could be cautery or there could be
Okay, there is a question somebody asked that why not cautery used here?
cautery is used not in this case, but laser could be used in case we had laser over here. And if there is a bleeding point, now if you see over here, it's completely stopped. So there is no bleeding point. It's a diffuse bleeding which happens because of the inflammation and the granulation tissue, which stops by itself. You don't have to do much work in stopping the bleeding. If you can see on the mirror view, you can see the apex, and we need to prepare this apex as well, but first we need to remove this tissue from the central incision.
Sir, administering local anesthesia, some extra local anesthesia on the palatal side.
Yeah, sir is administering palatal anesthesia to augment what we had anesthetized initially him with, and we've seen that a good number of people are posting comments right now, and we welcome all your comments. We want you people to come out with your questions, your queries, your suggestions, your comments, or we are happy to share all the ideas everyone has around here.
We'll be giving also some local anesthetic and also at the same time some analgesic.
So we are giving him some analgesia also right now, because the lesion is very, very large.
Yeah, I have some comments. Yunda, Ilya. Let's jump.
We have opened up the tissues, we have curated it out, we have done the root resection for 2 teeth, only root resection for 1 more tooth remains. For purpose of endodontic intervention, we need to be very patient and wait here, because we have not resected the root. If endodontic surgeries, if you want to only enucleate the lesion, you go and radically resect the apical 3 to 4 mm of the roots. Starting. So we wanted to salvage the roots, so we worked around the root for quite some time. We removed all the tags and tissues and adhered granulation on the parietal aspect and the inferior border of the lesion in the anterior maxilla. Now what we have to do is, after the curettage is complete, we have to achieve utmost anesthesia possible, as far as possible, so that we can actually see the root in a small mirror. We are going to enter the root from the retrograde approach. We have small microscopic ultrasonic tips. These are the tips like your scaler only, but they are angulated for specific angulation of all the roots. For upper central incisor, the angle is different. For the lateral, the angle is different. For canine, the angle is different. And rest of the roots in the upper and the lower arch for posteriors. So we have selected an appropriate retrograde cavity preparation tip. We are going to resect the roots by 3 millimeters, and subsequently we are going to prepare a retrograde cavity, and followed which we will compact mineral trioxide aggregate. For that we need absolute isolation, so that the MTA does not get washed away during the procedure or irrigation. So it will be very precisely performed. It's a patient job. It will still take a lot of time for this procedure to go on. This is wanted. Use the microscope camera, please. We have got a question why there is no cautery used. Okay. It has already been answered. Thank you. Sir is using an air rotor handpiece with head having 45-degree angulation. If you can see, sir is resecting the root apex. He is rounding off the cut which I had taken. Any sharp edges anywhere in the bone or the tooth should be avoided. Handing it over to Dr. Unmesh Khanvilkar for comment.
Now sir is working on the root surface of lateral incisor. As Dr. Abrar mentioned, this is the 45-degree angulated handpiece. It's used on the air rotor end.
खत्म कर रहे काम आपका पूरा निकाल दांत भी ठीक करना है साथ साथ में पेपर लिया पेपर
So using long shank tapered burr for the root resection of left central incisor. This is diamond. This is without it. This is without it. Diamond one.
So I've magnified a little bit to see where exactly we'll be going into the retro preparation over here.
Can you show the bevel? Sir is showing you the bevel and see the at the retrograde area. So showing you the view at the retrograde area after the root resection. The nicely cut root. You can see the GP. Now, sir, we'll be using ultrasonic tip, which is specially designed for the retrograde area with the diamond coated tip.
Canal very quickly and remove the gadapacha. This tip is designed to give you 3 millimeter of the apical preparation, retrograde.
Using an ultrasonic tip will give you the exact precision what you require to prepare the cavity at the retrograde area. Tips will give you the good accessibility as well as the good visibility while you are working.
And more importantly, will go parallel to the line of the canal.
Yeah, that's a very important tip from sir.
You can see I have already prepared both the retro preparations.
Yeah.
And
Now,
I'll
sir,
just show you the retro preparation from the mirror view.
So showing you in the mirror the retrograde preparation.
We'll pack some cotton in the floor so that we can, work on the whole section next to it. It will not fog the mirror. Next to the mirror.
So he has packed the cotton very nicely, and now he will go ahead with the retrograde preparation, retrograde filling. You can see the cavity in the mirror.
फिलिंग कर रहे, पैक कर रहे बस. So you can see the retro preparation inside the root apex. We just don't allow blood to go in, so that it's easy for us to pack. So you can keep some gauze piece over there, or you can keep some cotton over there, or you can keep gel foam also over there, so that will not allow bleeding to take place. So there are ways and means of isolating this area while you are packing the MTA. So now we'll be having some MTA to pack. We are showing you more paste.
So can you tell us about the importance of this plugger, what you're going to use, why we should use this particular one, and what is the advantage of that?
So this is a microapical placement gun, or also can be called as dough gun carrier. So it can be filled up, and you can directly place MTA right into the canal. So you fill it up and then inject straight into the canal from here. So you can see I've injected straight into the canal, and I need some retro condensation tips to push my MTA inside the canal and condense it.
Just to tap. So what are the options we can have other than MTA, what we can use at this place?
We can have options like biodentine, bioceramic putty.
Okay.
Therefore, tomorrow when I'm performing the surgery, I will use bioceramic putty, so that simplifies the work. Okay. And you can do it much more quickly.
So what are lots of PG students are watching today? So see, you can. This is a very good session, and sir is giving you all the tips. What are the different materials we can use? So what is your concept about super EBA for at this stage?
Super EBA also can be used, but slowly falling out of favor now, because the MTA and bioceramic materials are not just the sealing agents, but they are also bone conductive, inductive materials. So they will allow or induce a faster healing around them and more close healing next to them. If you see the packing of the lateral, which we have done already, I would just like to show. Keep some cotton.
Cotton. It's a wet cotton, and sir is trying to pack the MTA, giving a good finish to that retrograde filling.
Now you can see the finish, completely sealed apex in the mirror view if you can. We'll do the same with the central. Yeah. और mix करके one by one each tooth has to be filled up, and you can see how it injects out of it. In between you keep cleaning the tip so that it doesn't get blocked. You can use a retro tip like this to condense MTA and then place some more so that you have a dense packing of MTA inside.
There are various, sir, I guess a lot of hand instruments also available with the particular
Yes,
angulation.
there is a complete set available which we can use with different angles so that it's easy for us to reach every side, including the posterior teeth. I think again on day after tomorrow when I'm doing the live surgery, I will show that set.
Thick.
The spoon excavator over here can be filled up and placed, and for the same thing the other side can be used for smoothing. Sometimes you can devise yourself to work efficiently. As you can see over here, I can just place and then reverse to smoothen it. I'll place some MTA and I'll condense.
Sir is using the ultrasonic tip. This is without diamond coated, and sir is just using it to hit the material. It's not active. It's sir is just using for the condensation. Okay. Empty then.
And you can plane it with any flat instrument. The opposite side of the a plastic instrument, flat instrument, cement carrier. There are MTA carvers also available. Again, I'll try and show them on day after tomorrow when I'm performing live. So you can see you can use any kind of a condenser which is suitable, and then you can smoothen and carve it out. After a while, the MTA would be hard enough for you to carve. You can see now I'm able to get a smooth finish, and I can wipe off the excess again with some cotton. Leave some cotton here. So this part of the central and lateral is completed actually. I'll just inspect the other central because we were just about to start. and then I thought I will finish this part because they are not connected to each other except for the lesion. This seems to be very well obturated, as you can see on the mirror view. I'll just try and show you on the mirror view. Yeah. So here you can see clearly the other central. Well obturated, and even the preparation is quite light on the surface, so I can straight away, if I want, prepare and put MTA.
Now, sir, we'll be doing a cavity, retrograde cavity for the left maxillary central incisor. We are shifted to diamond coated angulated tip of ultrasonic, which will prepare the cavity. Local. Holding the muscle. So the whole lesion is coming out from the other central. We are almost done. Again, take a blade if you have and incise it. Yeah. I can separate it from the fibrous tissue. That's it. We are done with the other central also. So somebody was asking about, can't we be quick enough? You can see I could finish one other central in just 5 minutes time. And I can do the retro over there. So he's preparing a cavity, retrograde cavity for the central incisor.
As you can see, it's happening very quickly, and we are able to prepare the retro straight away. So the retro is done, and now we'll seal it. Lesions are out. As you can see, you can go around the wall so that you can remove all the debris also from the wall. And normally I would like MTA to be ready while I'm doing the preparation. So I'm ready for the retrograde. As you can see, we can work quickly if there is a good kind of a backup available, which is good in terms of assisting over here. This is a gun I am using to seal the apex, and I will clean this area so that I can show you on the mirror view. You can have this small mirror, and you can see the central also filled with MTA right at the apex. I'll just centerize the microscope so that you can see it, and also clean the surface with dry cotton. A little bit of tissue tag which is masking the view, so I'll just remove that tissue tag. And now you can see in the mirror view the central incisor. I can place some more MTA. There is a scope, so let's put some more MTA. I can use my and then dry cotton is in my cotton. And you can see patient's pain is almost gone. Once the lesion is out, retro preparation is done, MTA is placed, we are ready to close. And now the bone augmentation for healing, better healing, so we will place the PRF. You want to irrigate? I would wait for irrigation because the MTA is still hardening. But I hope you can appreciate the socket now, such a large one, completely covering the entire cavity. We can check the entire surface, which is clean now, and bleeding is stopped, pain is stopped, retrograde is completed, so we can just now place our PRF and then suture. We are done. Placing PRF, you can. See, we are waiting a little bit time for MTA to harden so that it doesn't get washed away while you are irrigating. Once it is partially hardened, there is no need to worry about MTA getting washed away.
So around what, how much time we should wait?
3 to 5 minutes. I think for the central, right central and lateral, it's already hardened.
Okay.
The left central is hardening. By the time they prepare for PRF to place and then irrigate, will be done.
The next procedure, you will be putting the PRF inside?
Yes, we'll be placing the PRF inside. I would request the oral surgeon only to do it. It's their prerogative most of the time. So, and this is a college, so we have the collaboration with all the departments. You can come forward. I will just move backwards. It is still visible on the screen, no issues.
I can add some, what you can explain what we can use to support.
We are placing the PRF. Our oral surgeon is placing the PRF. Take the suction inside, please. Keep it dry. And this is taken from the derived from the blood that we had taken from the patient some time back.
How you give the importance of PRF in such cases? What, how it is helpful for
this has got all the supplements for, you know, initiating the healing of the tissue. So there is a faster healing of the tissue. There is a support. You can also use collagen sponge to support the PRF underneath the PRF, so that it forms like a membrane on the surface. So there are ways and means of again handling this. You can put an allograft, and then over that also you can put PRF. You can also place bone derived from patient somewhere and place it. But I think this is what we have right now, so we are going to be satisfied with this. It is still good enough to initiate the healing, because it is derived from the patient's own blood and the plasma. So it has got all the ingredients for the healing, rich in it.
So this is very like a large lesion. So, but when there is a single tooth or a small cavities are present, so what do you suggest? Do we have to do PRF in every case?
No, like if it was only a single tooth involved over here, I would have not placed PRF. If the palatal plate, like in this case, cortical plate is intact, then also you don't need kind of a membrane. Only if the palatal plate is also gone and the buccal plate is also gone, then you need membrane to support it.
Are there any methods where we can support this PRF, or like it should not move from the place, or it's?
Yes, you can suture it.
Okay.
You can cover it with a glue. You can place collagen mesh underneath and again support it. So PRF can be held in position in various ways. But here we are looking at purely as a bone graft material, not as a surface covering, as a membrane. So we'll be just closing the tooth now. And you can see patient is, are you comfortable? Yeah. Huh? He's saying yes for the first time. You're happy that this work is over? We'll be suturing it now to close it.
Say anything about the suturing material you would like to add something?
So we'll be using Vicryl absorbable sutures. The size we are using over here is 40. Normally under microsurgery we use 50, 60 and 70. This is a very large lesion. We need the sutures to be strong. So we use 40. There is no place for 30 or 20 in this. And sutures can be removed in 3 days to 5 days time, or they can be self-dissolving. Alright, so let's go ahead and finish the case. So normally I would ask oral surgeon, where would you start suturing? Then I'll give my opinion. Yes, so even I agree with you, I start with the frenum area so that there is no movement of the flap taking place. So I first take a bite on the frenum area.
So as everyone is saying, it's a very important tip given by Dr. Pedi Joshi sir, that always start in the frenum area.
Then go interdentally into the palatal aspect.
So you have so many years of experience. Why you are following this particular thing? What is the special reason, or what is the reason behind that? Can you?
One important thing is that palatal tissue is hard, so it will hold the suture properly. Second thing, you will be able to tighten the knot in a way that the flap will adapt to the gingival margin properly of the tooth. And this suture will not come in the way of the patient in any way. Once I take a bite on the palatal side, the bite is already there, so I just need to come back on the labial side. And then you can even just use it like a floss. And then come to the labial side, and now you can just tie the knot. And when you tie the knot, support the knot so that the tissue remains where you want it to.
As you are seeing on the screen, the one knot which sir has given at the frenum area, it's completely stabilized the complete flap. For the most of the flap, you can see it's getting stabilized by the single suture. So it's easy for the surgeon to go ahead and give the other knot.
All the anterior, all the horizontal flap sutures are given like this interdentally, and make sure that the gingival tissue is taken all the way to its original location. The papilla is actually sutured where it was. Might have a very mild imperceptible recession, but you will not see major loss of tissue over here. The palatal bite is taken. Now I come back to floss around the tooth because it's an open contact, so I don't have to worry about passing and you can see the flap is almost in position.
ठीक है ठीक है tweezer.
Okay, there's one more type of suture you can give over here is go around the tooth from the other side. So you can go from the mesial of canine, then come back and out on the distal of the canine. Now I can loop it around on the canine, and I can have both the papillas tightened together. I'll have to take this papilla as well into the suture. Now this way I've avoided taking a bite on the palatal tissue. Sometimes, it helps you to pull the flap down and hold it tight against the tooth surface. So you're actually compressing the margin against the neck of the tooth. And finishing 2 sutures in one go. Later on, of course, we'll first finish the vertical sutures and then we'll close the horizontal ones. That was only for demonstration, but I generally like to go individually on every interdental space. So the adaptation is good. Give me another suture. A bit of a blue ones.
I think this is also last horizontal suture, right? This one?
Yes, this is the last horizontal suture. So would you like to give the horizontal ones? Vertical? Maybe? Or you would like to finish it? Turn this way a little.
So now sir is giving on the vertical incision. So on vertical incision, particular care we have to follow from which side to which side we should go it?
Go it from the inner of the flap to the outer of the flap. Never take it from this side to this side. Take it from the inner of the flap, that is towards the surgical side, to the outer, like this. And then once you go there, make sure you retract your lip properly so that the line remains vertical and doesn't get folded over there. So many times I've seen my own assistants, not the doctors but chairside assistants, they release the incision and there are folds coming over there. So if you want the clear cut suturing, then you should hold it vertical properly.
So it's a very important tip when you give suture at the vertical incision. You retract it first properly, keep it retracted, and then go from inner side to the outer side, and then give the suture.
One more there, and that side is done. Then we'll look on the right side. Right side, I think Dr. Abrar had not given a very deep, long incision. So we'll take the last one, marginal.
So how many sutures sir you prefer generally on the vertical incision? It is depend upon the depth, or one or two is enough?
To tell you frankly, yes, even one is enough.
Okay.
Because once you close the incision, it remains stable. Generally, it doesn't move because it's in the depth of the concavity between the two teeth.
Any particularly sir, how much tight it should be, or it should be a little bit loose, so that
Not very tight.
Okay.
Because you don't want the vessels to be cramped. At the same time, you want tissue to move freely when patient is talking or eating or opening the mouth. These incisions done with 15C blade, they heal very fast. So we'll take one over here. Let me focus the microscope over there. Are you able to see?
Yes. Take the battery change. Again, you all can appreciate the sutures from the surgical side.
You can even take a single knot like this. Then you need to take 3. and the second one you should take reverse. Normally I prefer double or triple knots. Okay, so I think we need only one over here. There was a frenum which Dr. Abrar tried to avoid taking an incision on. That's why there was a very short incision given, vertical height. So it's all done. And you can appreciate the way the tissue has adapted over the, yeah, you can flush. You can wipe, get gauze.
So you can clearly see the surgical site. It's in nicely suture back to its original position. Right from premolar area of right hand side up to the lateral side of the other side.
Dr. Abrar, you would like to answer some questions over yours.
So we have concluded
so,
the.
You will give the operative instructions.
You proceed. That she will manage.
Public
Huh?
for the public.
Okay, so you please continue, sir.
Okay, so the work is done. Patient is fine. Are you in pain right now? No? Thoda? Okay. So, because we gave additional supplemental local anesthesia and we gave ketorolac, dispersible during the surgery, patient is very comfortable right now. The patient straight. Straight karo, madam. Patient go straight karo. So what are the instructions patient has to follow? Most important thing would be apply ice on the outside of the lip area, covering the sides continuously for about 15 minutes, then a break for some time, again 15 minutes, break for some time throughout the day. Today and tomorrow. Tomorrow is going to get swelling right up to the eyelids. So he is going to look like Hanuman tomorrow. Second thing is not to open the lip and check the wound because you can displace the sutures. So patient should not unnecessarily touch the site. Third thing is patient should rinse frequently with chlorhexidine mouthwash so that the area remains clean. Fourth thing is that patient should not brush the anterior canine to canine area, the surgical site where we have worked on. He can brush on the lower jaw but not on the upper jaw. Patient should not eat for at least 2 hours, should not bite from the front teeth. He should be on soft diet for a couple of days. Rice, khichdi and stuff like that is fine for patient. And you should take with spoon, take it in the mouth and then chew with the back teeth so that the front teeth are not involved in biting. We should not bite anything with the front teeth. So food like pizzas and burgers is out of question for some time. There would be some instructions to not panic if there is a little bit of oozing. There will be some oozing for the day. Tomorrow it will completely stop. There could be mild pain to moderate pain which will be covered with some analgesics that will be giving to the patient right now, and also some antibiotic coverage. So for 5 to 7 days patient will be on amoxicillin clavulanic combination antibiotics. I'm not taking any trade names over here. And also a patient will be on diclopera combination drugs, also with chymotrypsin, trypsin kind of enzymatic preparations as an anti-inflammatory. So this will help contain the swelling, help contain the pain. And as a co-supplement you can give probiotics for antibiotic, antacids, though he is very young. He may not get any acidity, but normally most of the patients get acidity with all these tablets, so you give some antacid as well simultaneously. Patient should report to us if there is any complication immediately. So some of the phone numbers should be given to the patient. One of the doctors should call up the patient in the evening or tomorrow morning to find out how he is, or he can come for follow-up, and the wound can be cleaned at that time with chlorhexidine or betadine. The sutures are self-absorbing, so you don't have to remove them. If the patient wants to go out, he can go away. Actually, most of my patients in my practice, they don't return for suture removal. So they come from abroad or from other towns. This patient can return 7 days later, 5 to 7 days later, the sutures can be removed, and he should be fine. Follow-up X-ray should be taken every 3 months for at least 2 years to see the lesion is healing or healed. At the end of a year, you can even repeat a CBCT to see if the bone is forming properly. So all these things are to be written and given to the patient so that patient does not forget anything. Anything more you would like to tell the patient?
Yeah.
It's like a big essay to the patient, so we'll write it down and give it to you.
We will give elaborate instructions to the patient separately. There's a question here. Sir, why was the space created after removal of the lesion not filled with any material? How will the tissues get supported then? So primarily the surgical plan was to remove the foreign body. There was a huge chunk of calcium hydroxide inside, so we removed it, and there was encapsulation. The encapsulation happens with a tissue along with infiltration of multinucleated giant cells. So it's a granulomatous tissue which has to be taken off because it keeps on resorbing the maxillary bone and expanding itself. It would have perforated the nose as well as the sinus in some time. So now essential was the removal of the foreign body per se as well as the lesion surrounding it, the soft tissue lesion surrounding it. So we have taken it out, we have excised it and curated the bed. After that, the question goes in the right direction that you had to remove it, and now we created a space. A created space could have been grafted with a bone graft. However, in this case, there was massive infection. The site was infected. It is not a good recipient site for a graft tissue. Secondly, the patient is very healthy and very young, having enormous healing potential. And if you see, it is not perforated palatally. Facially, you have achieved a very nice closure. Mesial and distal walls are well confined and defined. You could curate the walls with a nice curate. So there is solid support for all the tissue. Now what will happen here? We had drawn the blood, we had showed online. After drawing the blood, we have made PRF and we have placed PRF there to promote a better amount of healing or just to expedite or accelerate the healing process. Now here the lesion is going to bleed from all the sides. The PRF is sitting as a reasonably semi-solid gel-like material there, and this clot will form in some time. The clot will organize itself and slowly there will be bone development, and bone will fill in this tissue approximately this size and this age. For his condition, maybe after 8 to 10 months we may see abundance of bone in the entire lesion. This patient will be put to follow up every first month, second month, third month, 6 months, 1 year, and yearly once subsequently to keep a check and tab on healing process. So there should be evident bone deposition over the period of time. If there is no bone deposition and any appearance of the symptom, patient will be told to revert us back again. Okay, I hope I answered the question. And now, ma'am, please. Our respected Dean Madam, Dr. Vasundhara Bhatt Madam is with me here in the operating room. We have received enormous support from Madam for the whole program. So I request you, ma'am, to express a few words here.
Congratulations to the team. And comment of endodontic endodontics and that the microdentistry department. Lots of efforts have been put up in planning this program. Almost a month Dr. Abrar was in planning the program, taking permission from the higher authority, and in collaboration with MUHS, this whole program has been organized. So hearty congratulations, wonderful case I'll say, which has benefited all the participants who are there online with us, definitely they have been benefited with it. Very meticulous the procedure has been carried out, and the finish is also the good, and I think the patient is happy. Are you happy? Is there a pain over there? No, no? Some amount of discomfort will be there after doing so much, almost 2 hours work has been carried out. So once again, hearty congratulations to the whole team of microdentistry headed by Dr. Abrar. Thank you.
Thank you so much, ma'am. I request madam to felicitate Dr. Priyesh here. He is an oral maxillofacial surgeon. Dr. Priyesh, thank you for all your support. He has been appointed as an observer from Maharashtra State Dental Council for this program. Maharashtra State Dental Council has given us 10 credit points for this event, and we are thankful to him for accepting the invitation and being a big support. He has actually contributed physically also to this whole. His expertise was very useful. So thank you, sir. I request madam to give him a certificate of appreciation.
Thank you for being an observer from the market.
Thank you so much. And thank you everyone for patient listening and being a part of this whole event. The intention is clear, pure academics and clinical training in the best interest of the patient as well as all the students around. Be very frank with your comments, suggestions, your questions, your queries, your doubts. Whatever intrigues you, share with us, good or bad. Most welcome. We want to learn from you, and we want you to see the experience of the stalwart here. P.D. Joshi sir himself was working, a lot of other people are working. Once again, I thank Dean Madam at first, then Dr. Reshma, who has been pivotal in managing the case clinically, Dr. Shaili, who has handled the entire technical part very, very well, Dr. Wendy, who helped us with the registration, and most important, Dr. Prachi here, who has helped with all the registrations. One last announcement I would like to make for the day. Tomorrow, the surgery only. Tomorrow there is no lecture. Tomorrow we have kept a simpler case. This was a giant case. This was a lot of procedures to be performed in the same case. So tomorrow's case will be short, simpler. Details of the case along with the link will be updated on the same group. Thank you so much, each one of you, for attending the program. And all of you who have seen the surgery, the case, kindly send the messages on the group so that certificates can be sent accordingly. Thank you so much.
Sound of